Dared. The bats have left the bell tower. The victims have been fled. Red velvet line.
Thank you. Good afternoon. I'm Howard Hu. I'm the Dean of the Dalla Lana School of Public Health. I left Harvard, and it's a great place to leave. How many people are here at the Summit Conference for the first time? Yeah, we have quite a few. And we designed the conference that way so that busy people could look at our program and come join us for those aspects that are really resonant with the things that you do. But I have to share with you that the summit was also about integration. I just want to make a couple of comments on that before I introduce David Henry, the co-chair of our Big Data for Health Committee. This is a summit that's really all about what a university with wonderful scholars, each expert in global health in their particular area, can do when they come together and think of something they can do together that address the more complex, and as some of our scholars say, wicked problems in global health. And those are difficult ones. And I invite you, as you delve into today's issue, Big Data for Health, to also explore some of the other themes that were discussed today, because each one of them touches on Big Data for Health in a very big way. For instance, we started off trying to define what is health, because the WHO definition that's been used for 14 years, that health is a state free of physical and mental disease, is out of date. We have to think of health as a much more expanded definition that includes resilience, functionality, the ability to bounce back from physical challenges. And most of us over 50, like myself, we're not free of disease, but we consider ourselves healthy too. So there's new metrics that are being developed called salutometrics that are key to understanding, well, how are we even going to measure health? We had sessions on the convergence, that is the ability of countries to now look more similar, whether they're in low and middle income countries or high income countries, because of huge advances that have been made in vaccinations and approaches to malnutrition and infectious disease. But to actually finish that agenda, gigantic challenges that on some way have to be studied by bringing in other sources of data that help us understand the politics, the sociology, and the other aspects that really make global health advance. We just had a session this morning on politics, privilege, and power, and even those people who get access to the data we want to analyze. That is also a big issue in global health. So I invite you to explore the other themes that were part of our conference. In fact, many of them are captured on these wonderful visual graphics that were made by our graphics visual artist. A lot of them are outside now, Lisa Edwards. And one of the tasks that we've already put forward to the rest of the conference participants, and we invite you to, is to add to the conversation and what can a university do with its partners, again, through our Institute for Global Health, Equity and Innovation, to advance the global health agenda. And we do have a Paul Everywhere app for making those inputs, and we'll try to scroll that up on the screen if we can. And we also have various other ways of getting feedback to us through tweets and other means. Now today, this afternoon, we're going to finish up this last session on big data for health. This is a huge, huge opportunity for us here at the University of Toronto and in Canada. You'll be hearing from some of our leading scholars regarding some of the resources we have. But part of the message and the conversation is about going places where people haven't gone with the big data for health agenda. And as someone who does, I guess, a version of big data for health myself, I can attest to having spent many years at NIH strategy sessions arguing that big data for health is not just genomics, it's not just biobanks. There's so many other important sources of information to bring to the table to really understand the upstream determinants of health. And I'd also mention that, the University of Toronto has among its strengths a very big cadre of social scientists who challenge, understand what are the questions that should be asked. What should we actually be gathering for data? It's not just analyzing existing data. So there's a lot of big questions to explore, and I hope you really enjoy today's session. And they'll also tell you about something, some other activities they'll be doing after the summit. So let me introduce David Henry. David is an outstanding, renowned pharmacoepidemiologist who was the president of the Institute for Clinical and Evaluative Sciences, one of the largest sources of data in the world, with administrative health data on over 17 million Ontarians for over 20 years. And we're very fortunate to have recruited David to the Dalla Lana School of Public Health this past year, and he's co-chairing our big committee. Please welcome David Henry.
Thanks very much, Hart, for that introduction and for placing this session in context. And the context is fairly clear that much of what we talked about this week in terms of improving global health and the ways of improving global health require us to be able to measure the outcomes of what we're seeking to achieve. And that requires data. And this is a data session. So in comparison with some of the sessions, the more philosophical sessions that have taken place this week, this is kind of geek central. These are the people, a lot of the people here today like data. So they like to sit and look at data. And so we are going to make this a little bit different from some of the other sessions, in that we're going to actually have presenters and we're going to have slides. And believe me, for those of you who've been at some of the other sessions, that has not been the format. While we're underway, you'll see that there are tweets on those who have not been at some of the sessions already this week. There are tweets on the board to my right, to your left. You'll also see questions come up on the 2 lateral screens, and you can log in and answer those questions, put their opinions about some key questions, and I think you can do it through text. They're not up there yet, but I think they'll arrive later. For a start, I'd like to pay tribute to my co-organizer, Dr. Laura Rosella, like me, on the faculty at Dalla Lana. And those of you who have worked or know Laura will know that she is the true intellectual driving force behind this presentation. It's just that periodically they like to put older men up to say, to introduce sessions, but Laura, who will be taking on the coordination of some of the session later on, trust me, is the one who's really driven the ideas behind this session. I'm really grateful for that. The session is really in 2 parts. We're going to have a series of presentations, then we'll have a brief panel discussion that I will attempt to coordinate. Then we're going to have a break, and then we're going to come back and do what we call 2 deep dives into 2 examples of data. Fortunately, we've got 2 really good people to lead us through that. Professor Leslie Roos, who a number of you will know or have heard of, from University of Manitoba, and we're going to deal a little bit more with the social data, their implications for health. And we're very fortunate to have Zemin Chen, who's here from University of Oxford, who is really directing the Kadoorie Biobank, and talk a bit about the linkage of biobank data to outcome data and hospitalization data. So we've got a lot to get through. I'm going to get started. Our first speaker is from Toronto. That's Professor Prabhat Jha. He's from Dalla Lana, from St. Mike's. The bios are in the book, so we're, like the other sessions, we're not going to do extensive bios. One of the many things that Prabhat has done in the world of global health is the Million Death Study in India, where they've used some very interesting techniques to get round the lack of a routinely collected data. So Prabhat, I'd like you to open the session. Thank you.
Thanks very much, David. Thank you. We've got a very limited time frame, so I'm going to start with my conclusions, which are that the enormous improvements that we've had in the 20th century in premature mortality suggest that big declines are possible in this century. And I'll talk about a particular recommendation for reducing mortality by 40% before old age. Meaning in young life and in middle age. The definition of middle age changes as I grow older, but mostly I'm going to talk about before age 70. And then I hope I can convince you that counting the dead and describing causes is central worldwide, including in this country. So I'm going to give you lots of numbers, as David alluded to, and I apologize. You know, the criticism of epidemiologists is that we're number crunchers like accountants, and that's not true. Accountants have more personality. But here's some numbers to start with, and it starts with an amateur astronomer Edmund Halley, that in between finding comets was also looking at patterns of mortality, and he studied 1700s Germany in a closed community and created the first life table that you see here. And the findings shouldn't be surprising, that most people were dead before age 70, but even before age 10, about 30% of the population was dead. And that's been human history, pretty nasty, short, brutish, as Thomas Hobbes wrote. The remarkable improvements that have occurred, for example, in the United Kingdom, really have occurred between the time period of 1816 to 1910, where child mortality was halved, and by 1960, where child mortality practically was eliminated. And then between 1960 and 2010, it's been as a result of smoking cessation and secondary treatments. So we're in the midst of this 200-year transition worldwide, including in developing countries. So if you take various countries, they're actually at different stages. Now, the process of reducing premature mortality has been more complete in high-income countries, but it's gone faster in low and middle-income countries, and that's important. So if you look globally, what happened just in the last 40 years. Well, at 1970 rates, 40% of males, 50% of females were dead, or sorry, survived till age 70. And that went up to 60% for males, 70% for females. And we proposed in a recent paper, is it possible to think about roughly 80% survival? And that would translate to a 40% reduction in death rates in 2030 versus 2010. And it is possible, and because if you look at the past patterns, I apologize, this all looks like kind of sperm trying to find destinations, but they're all going in the right direction, which is downward. And this particularly you see in low-income countries, that their mortality today, for example, take an age group of 0 to 49, which is this one, is lower than high-income countries was comparably in 1970. So they are going faster, and that opens up the promise for doing much improvements very rapidly. Now, but there's obvious things to avoid if you want to have improvements, and there are three things: HIV, vodka, and war. So HIV, the example you see that, look what happened in South Africa to mortality in men before age 50. Was coming down nicely, along comes HIV, boom, along comes ARV treatment, comes down. In men, vodka was mostly responsible. This is Gorbachev, that's Yeltsin retiring. War in Iran was basically the Iran-Iraq war and ended. By contrast, look at other populations. They've had a continuous decline. So avoiding obvious catastrophes is one strategy to improve health. But another key one, often not often discussed, is the simple fact of understanding why people die. So worldwide, there's about 60 million deaths, roughly, and we're concerned roughly with about the 50 million in low and middle income countries. And most of these occur at home and without medical attention. So what do you do to get the causes of death in this population when you don't have hospital statistics? Well, there's an elegant solution from 140 years ago by the Sanitary Commissioner of the Government of India, who wrote, for sanitary purposes, it is indispensable to know the relative mortality in small and, as far as possible, well-defined tracts to ascertain the death rates in each of these communities, to see how far they arise for preventable causes, and to apply the remedies. That's what we're doing in the Million Deaths Study. So the idea is simple. Take 1 million homes all over the country, take a true snapshot, send teams to go out and listen to the house, much as way as a medical student is taught to listen to someone who comes through a hospital door, and get a history of what happened in a half-page local narrative and some checklist questions. Then that's converted into electronic medical records, which then are sent to 2 physicians independently assigned, and they have guidelines and adjudication and all sorts of quality control. And the broad approach that we do is study all diseases, work with the census department, and keep things dirt cheap. That's the real magic of this study, is the conversation that you can have with 1 million homes. The 21st century gee whiz stuff is using laptops to capture data and GPS to track information. That's the new innovation, but the main innovation is simply knocking on doors and having a conversation. So what have we learned? Well, I'll just show you some results very quickly. Basically, everything that's of importance in terms of big causes of death you can study. But also, we learn how little we know, which I'll show you an example, particularly for adult mortality. So let's start with a looming demographic disaster, which is selective abortion of girls before birth in India. And our study, paired with the census data, was able to show that over time, what's happened is the sex ratio, meaning the proportion of boys or girls to boys per 1,000, has skewed substantially, such that this range is the normal biologic range. And in time, over a 20 years period, it has skewed substantially, such that most of Indian population today live in places where the sex ratio is unusually low or abnormal. And from this, we're able to calculate what are the overall numbers. And roughly, we say very broadly, 4 to 12 million girls aborted, of which half have just been in the last decade. This problem is getting worse. It will be worse by the 2021 census, and maybe after that it'll get better, but it is a problem. Let's turn to another example, which is malaria. The World Health Organization had estimated that India only has about 15,000 deaths a year from malaria, and most of those were kids. But malaria is not just a disease that you can treat, you can cure. And if you cure a disease, you have this nice public health problem of not being able to estimate the death rates. So what we did is we asked houses, is there a death? Did they have an acute fever that killed them? And then they gave details of those. And those, based on physician assignment, revealed a U-shaped pattern of malaria mortality, that it killed not just kids, but also adults, and that where malaria deaths occurred were almost exactly the same distribution as where the most dangerous type of falciparum malaria was reported independently by the malaria program. Now, this has spurred a lot of controversy, but it does suggest that getting an interview of people who don't show up at the hospital and finding out the crude causes of death is informative. Let's keep going on other examples. One of the modern epidemics in India is smoking. And among males in India that smoke cigarettes, the Western cigarette patterns, they now have a decade of life lost, which is surprisingly similar to the mature epidemics, meaning men who started smoking earlier in Japan or in the UK or in the US, but also to women who have been smoking like men seriously. And this was all documented in a very nice meeting that Zhenming Chen and I were at on October 28th, 2012, which was Richard Dahl's 100th birth centenary. And all these results came out at the same time. And here's how Brian Williams from NBC summarized the results.
And good news and bad news on the smoking front from the New England Journal of Medicine. They state flat out, smokers lose at least 1 decade of life expectancy over non-smokers on average. The encouraging news here is quitting before 40 reduces the smoking-related death risk by 90% compared to continuing on as a smoker.
60 years of epidemiology in 22 seconds. And it's right. And one of the important things is because the risks are so big, the benefits of quitting are also ridiculously big. So what we've shown, and now confirmed in those other studies, is that those who quit, let's say by age 30, get back almost all of the 10 years of life lost. Quit by 40, get back 9. Quit by 50, get back 6. Even quitting by 60 means 4 years of life returned. And this is important to help the messaging for developing countries. In India, the patterns are such, as I showed you, males who smoke cigarettes lose 10 years. The men who smoke the local bidis lose 6 years. And the cigarette is displacing the bidi. And that's very much the strategy of the tobacco industry, is to get rid of these smokers and have them smoke cigarettes. Okay, let's turn to other things that you can do with big data. Well, Yuri Maher came to me from Ryerson University and said she wanted to study air pollution. And I said, all right. So we looked at the satellite reports of the concentration of particulate matter 2.5 micromillimeters, which is the really small toxic stuff that gets deep in your lungs, and did a very simple but robust regression, spatial regression, to look at the impact of these on cause-specific mortality. And the finding is that overall, there's about 300,000 deaths from smoking in India. The World Health Organization says it's about 600,000, but that's mainly because they've used Western evidence superimposed upon Indian patterns. So that's a dramatic overestimate. And even the Chinese estimates are based upon that same logic. So in both populations, there might be an overestimate of the degree to which air pollution kills from heart disease, but probably an underestimate to the degree that it kills from chronic lung disease and ARI. Another more recent study that Anna Dare has done with us was a simple idea that, do surgeons save lives? I believe so. Abdullah Dar is a good friend of mine. I know he saves lives. But we wanted to look at this in a quantified way. So we looked at acute abdomen deaths, deaths that have to be seen within 24 hours. and identified hotspots and cold spots across the country. And sure enough, the odds ratio went fourfold if you lived more than 50 kilometers away from a functioning surgical hospital. It made no difference if you were next to any hospital, but being next to a surgical hospital actually reduced your mortality risk. All right, what else can we do with these kind of big data? Well, some fun things that we're doing is doing the world's largest randomized trial, which involves randomizing politicians. We didn't need IRB because IRB said politicians aren't human, you don't need consent. My father's a politician, so that's fair. And this idea is simple. We created local report cards and took the 600 districts of India and randomized them in a 2-by-2 intervention trial, looking at both basic health information on improvements of health, drawing from evidence. Anil Bhattacharya worked with us on this, and then looked at specific advice, including imparting training on tobacco control. And I've done a 2-by-2 trial, and we'll look at the results next year. Okay, those are things we know, those are things we do, but an important point of science is also to know things we don't know. So look at the differences, for example, in the risk of dying in childhood or in adults across India. There's a north-south gradient for childhood mortality, but by contrast, there's an east-west gradient for adult mortality. North-south differences you can mostly explain by levels of education, income, access to health services. Add those in, and you explain about 70% of that variation. Try to explain this variation and throw in other factors like smoking, alcohol, health access, and it actually doesn't explain much. So what's going on? I have no idea. But interestingly, the closest corollary of this east-west gradient that we found was a 1950s malaria map, early 1950s. And it suggests that, in fact, high levels of malaria parasitemia at that time might well have translated to something like low attainment of adult height and subsequent higher mortality. This needs biologic investigation of the kind that Zhenming is going to propose. And in this area, a low mortality area in Barshi, we're working with Rajesh Dixit to get a prospective blood-based study underway.
Death 101. About 55 million people die each year worldwide, of which over 30 million die prematurely. Which diseases are killing people? And what can we learn from these deaths? I'm Prabhat Jha, Professor of Epidemiology at the University of Toronto. Death 101 is a course to help you understand the importance of causes of death and its impact on global health. Now, don't let the title scare you. Death 101 is about shaping the future of global health by understanding patterns of death today and in the past. We've assembled a remarkable international team to share their insights on premature mortality and global health. At the heart of the course, you will learn the framework used to understand why cause of death is important and what we observe today. You will gain the skills to analyze cause of death, so to develop strategies that improve global health. I look forward to seeing you all online at edX Death 101 soon.
So that's a plug for the course coming out in January. So let me conclude. On the edX platform, it's open for everybody, completely open source. So let me conclude again that large declines have occurred in the past, and these do suggest specific strategies, specific directions that could help us with an ambitious goal of reducing premature mortality by 40%. And I hope I've convinced you that one of the best ways to help the living is to count the dead. Thank you.
You'll understand why we believe that Prabhat's natural Halloween costume is the Grim Reaper. He also mentioned, I'm sure he said at one stage his father wasn't human.
He's a politician.
What about you then?
Oh, he did.
So any pressing questions? We're going to have a discussion period at the end, but there were obviously some interjections occurring already while he was speaking. So any pressing questions that people want to ask of Prabhat while he's up here? I don't see movement, we're going to, oh yeah. Can you get to a mic? There's a microphone. Sorry to rush you.
Just wondering if you looked at occupational causes of death, and how did you account for maybe disguised occupational causes like tuberculosis that might have been affected by silicosis?
Yeah, occupation is very hard to define in the particular Indian context, because most of the deaths are rural, and the main occupation that's listed there is farming. So we don't know more details of the particular types of exposures, but there might be geospatial ways to actually try to look at different patterns in different areas. But we know from other experience that the risk factors that the occupation leads you to is probably going to be a bigger determinant than the occupation itself.
Thank you. I'm going to move on. So thanks for that. There will be, if we time ourselves well, there will be an opportunity to ask more questions. We're, in a sense, conceptually at one level, moving to the other side of the big data spectrum, if I can put it that way. We're going to talk about biobank data, and I'm going to invite Zhengming Chen to come up. Zhengming leads the China Kadoorie study, which is really, I think, a groundbreaking study in China, which includes analysis linkage of biobank data. I think points to the real value of that approach. So, Zhengming, please.
Good afternoon. Thanks very much for the kind invitation to this Global Health Summit. We have just heard story India. What I'm going to do is to describe a study which I've been involved in last 10 or 20 years in building. It's called China Kadoorie Biobank, and also describe the opportunities that big data generated for population health research, biomedical research, and also development of personalized medicine. China is a very interesting place, or unique place for large scale studies such as this. It has a very large population and has a very well developed infrastructure, especially over the last 30 years. And perhaps most importantly, it's large and well documented and, unexplained variation in disease mortality and morbidity. I mean, here just show the two diseases, esophageal cancer and nasopharyngeal cancer among Chinese women, and with the hotspots in some part of China, which the rate is probably 10 times greater than the neighboring counties or areas. This is cannot be explained by known risk factors. For example, for this particular disease, Chinese women don't smoke, don't drink, so certainly cannot explain this large variation. So this actually patterns persist for many other diseases as well. So this difference actually is driven primarily by the lifestyle, by environment factors that persisted probably for many decades during the since sort of maybe 20s, 30s, 40s. I think the disease pattern is going to change rapidly and sometimes unpredictably. Something to do with the public health intervention, some maybe to do with development of economic status. Here I just show one disease called liver cancer, which is one of the major cancers in China, in areas near Shanghai, where we have some project going on over the last 20 years. If you look at different time period among people born different age, different years, and over the last 20, 30 years, there has been very dramatic decrease in liver cancer mortality. 8-fold reduction among people aged 25 to 29, 4-fold reduction here, 2-fold reduction here, little change, and a similar change reduction is also seen for chronic liver disease. This is very well before the introduction of universal HPV vaccination. It's probably driven primarily by eradication of aflatoxin because of bad food supply and storage as well. Yes, it's aflatoxin, yeah, it's in the staple food as well. But I think the future will be very different, and it will be driven by many other things that are happening. And one of the main challenge, as probably I have already mentioned, is the smoking. So this is actually smoking consumption or production in China. Things that open up China or economic development, that's been a huge increase. And this will be followed for sure very large increase in tobacco-related mortality, morbidity, as has already happened 40 years earlier in many other countries, especially the United States and the United Kingdom as well. And the first in men, followed by women, and not just lung cancer, but a wide range of other diseases as well. So I think we do need to establish a large cohort studies, mortality registry, morbidity to monitor the evolving patterns or changing patterns of chronic disease, and also to study known causes of disease, but also to sort of uncover novel risk factors, both genetic and environmental. So I think prospect study is a very powerful tool to do because for obvious reasons, you can do the survey, collect the data before disease onset to avoid reverse causality. And also controls are selected from same cohort, so to minimize the potential confounding and bias. And also you can collect a large amount of data before disease onset, so you can conduct multi-omic studies at the same time. And you can study many diseases, especially if this linked to the health record, a wide range of chronic disease, not just fatal, but also non-fatal. But the key determinants, the study need to be really large, and also need to have a very detailed disease phenotyping as well. I think, in epidemiology studies, size really matters much more than most people thought. Here we just use the data from Oxford Coordinated Prospective Study collaboration involving 61 studies over about 1 million participants to study a very big risk factor, blood pressure with a common disease. So this is the results for 5,000. If you have a 5,000, which is a unit of Framingham study. So overall, you see a positive trend. But if you start to look at subgroup, the picture is quite blurred, or even you get complete wrong conclusion. Blood pressure doesn't matter outwardly. This is what we learned when I was in medical school in Shanghai back in early 80s. And then 50,000, much better focused. You start to see the clear picture, not overall, but also different subset of population. If the study is 500,000 and much clearer. But I think this is a very big risk factor. Genetic studies, the challenges will be even greater. So we need big studies. So during the last 10 years, we have seen a new wave of big cohort study coming up called biobank study. UK biobank, China Cadoric biobank is one of these. So this is a much bigger and much more detailed into the data collection. So the study involved over 500,000 participants who were recruited during 2004 and 2008 from 10 carefully select regions across China with a very extensive data collection by questionnaire, which is a computerized questionnaire, and measurements, and also most importantly, collection long-term storage of biological samples. And every few years, we would do periodic resurveys, a subset. All the participants are being followed up, hopefully indefinitely, through linkage with the health record, mortality, morbidity, hospital record. And so this is involve a close collaboration between Oxford Chinese Academy of Medical Sciences. And this is a map show where the study areas, locality, and it's the same size of Canada, but in terms of population, 6 times greater. And from freezing north, it's like here, start to snow in October, -20, 30. And also tropical source, very warm, nice, and a very well-developed urban area with a lot of high buildings, cars, and still inland rural area with very different disease pattern, risk exposure. So each size is 10 Framingham, 50, 60,000. So on its own, it's going to be very interesting to study particularly local disease. So this just shows the recruitment. It took us 4 years to recruit. We overshoot, instead of 500,000, we recruited 550,000. So we can claim bigger than UK Biobank. The mean age is 52, slightly more men than women. In terms of blood collection, almost complete. Only 96 samples not collected, so which is a great achievement. And over the last few years, we have also conducted 2 periodic resurveys with enhancement. So everything done carefully, industrial, very well planned, and use a lot of IT systems. This just shows the flow of a clinical station and assessment center set up purposely for the project. From registration consent, go through different stations, in some questionnaire interviews. And the whole process, it's about sort of 1 to 1.5 hours. And that's just maximum, participant can manage it. So daily recruitment, it's about 60, 70 a day per site. So that's a 600, 700 per, across 10 sites. And with a very careful quality control, statistical monitoring, but also recording of the interview. So you can listen and make sure, they follow the procedure. So this is very important for the big study. So they just give you some idea of some of the physical measurement. Some of them are added more recently, including CIMT, bone mineral density, and bioimpedance as well, and 12-lead ECG. So a lot of data collected. So this is a huge undertaking. One of the actually key elements for success, in my view, is the IT system. So my team in Oxford developed over 50 sort of IT system to manage the whole project, not just data collection, but also sample processing, shipment tracking, and to the stock control equipment calibration. So people don't need to remember, the computer system will manage the whole process. So very briefly, some sort of results. We have probably 100 papers in the pipeline. Just given the time, just show a few sort of results on some of sort of conventional risk factor to demonstrate the value of big study or study done in different population. So this is actually very simple bar diagram, number of participants by year of birth. So that's one of my statisticians said there's something wrong with the data. Why there's a big drop here, big deficit here? And it's true across all 10 regions, both for men and women. If someone knows Chinese history, you can figure out what happened during that time period. So this is actually quite important, not in terms of sort of social development, but also in terms of medical research. There's a fetal orange. And so this is actually a very good sample to study fetal orange because people expose you to extreme sort of poverty or famine. And you can study whether they're at increased risk of chronic disease as well. So we have a project going on. So this shows the variation of selected variables in China among men, very similarly in Chinese women. Education, this across 10 different regions, and then urban, rural. Alcohol drinking, green tea drinking, dairy product, spicy food. And people know Sichuan food, but actually most dangerous place is Chairman Mao's hometown. 100% eat hot spicy from age 5. So we have actually questioning, whether they do something. Height, weight, history. So some part of the heterogeneity are driven by different stages of economic development. It's more sort of prevalent urban and rural. But some are due to lifestyle that persisted for decades or 100 years. So actually, the great heterogeneity can facilitate investigation or understanding of a disease etiology. Some interesting results, which was published a couple of years ago, on the variation of blood pressure by season. This is a part of results of our quality monitoring. So actually, this is a 4-year period. You see blood pressure goes up, when winter comes, and it goes down again. So it's true across 10 regions. And this is a much more extreme among elderly, among people with a low BMI, for example, BMI less than 18.5, 12 millimeter mercury difference between summer and winter, very, very extreme. I think the main reason is driven by temperature. It's not due to measurement because everything carefully calibrated and quality controlled. So subsequently, we managed to get hold of meteorological data and plot each regions each day against temperature. Got very nice regression line. This is 10 regions in one straight line. So every 10-degree drop in temperature, blood pressure goes up by 6 millimeter mercury, with exception of perhaps here. So this is the area up in the Manchuria, very cold, but every household has a proper central heating. We have that question in the questionnaire. So I think this is definitely some news for global warming. I think it's important to keep warm, and may also help explain some very dramatic decline in stroke mortality, which started actually well before the introduction of blood pressure. So actually, environment is very important, and one of the major determinants of blood pressure is adiposity, apart from temperature. Here we have seen very striking relationship between blood pressure, and much more so in our Chinese populations than in other studies. So every 10 units high BMI is associated with almost 20 millimeter mercury difference in BMI, much more extreme than study in Japan, Europe, USA, Mexico, sometimes 3 times stronger. We don't know why. It could be genetic, it could be some other environmental factors. It could be salt, yeah. And if we look at the blood pressure and the stroke mortality incidence, very nice results. I mean, this is hopefully will be published next year. And also we can estimate the strength of a dose-response relationship. For every 20 millimeter mercury high systolic, ischemic stroke will double. Hemorrhagic stroke will triple, more extreme for hemorrhagic than for ischemic stroke. If we plot BMI against stroke incidence without adjusting for blood pressure, and actually you can see for ischemic stroke, this is very much driven by blood pressure. 10 millimeter mercury, or 20 millimeter mercury, or 10 units BMI, doubling the risk. For hemorrhagic stroke, we expect similar or much more stronger, 3 times. But what we see is much weaker. So this is actually, instead of rectal risk 3, it's 1.3. This is the standard for everything: physical activity, drinking, diet, alcohol, etc. So we don't really know what's going on. And that actually indicated as some important factors counterbalance the adverse effects of a high BMI on blood pressure. So this is something quite major and always discovery. So what we plan to do, and we have just managed to obtain a grant from MRC to do first largest scale multi-omic blood-based nested case control study. 5,000 cases and all confirmed, CT confirmed, and then 10,000 controls, measure everything, as well as smoking, drinking, blood pressure, but also genetic, blood biomarker, proteomics, metabolomics, and hopefully we'll be able to review some sort of novel risk factors associated with the increased risk. I think our plan is not just to do a nested case control study, particular disease, is to genotype all 500,000. So I think we're well on the course to secure large funding to do that, follow on the biobank. So this is my last slide. I think what makes CKB or other big studies special, first, it's prospective, has obvious advantages, especially for studying non-genetic risk factors, and very detailed, both in terms of collection of baseline, measurement, but also disease. I'm going to mention briefly that after talk some other linkage issues we're capturing, not just major disease, but all ICD-10 coded 4,000 different kind of disease, including some non-fatal disease. And also very big, so including large number of participants, so can allow very reliable assessment of causes, a wide range of disease, and also combined impacts of different exposures as well. So I think there's a unique combination of breadth and also depth, and hopefully will transform our medical research internationally, not only China, over the next few decades. So last but not least, I'd just like to acknowledge this is a huge collective undertaking, involve many hundreds of people who work over the last 10 years, and which is funded by a number of organizations, China Kadoorie Foundation, Wellcome, and also we start to attract funding from within China. So this is a website if you are interested for collaboration and for further information about study. Thank you very much for your attention.
Did you ask about Kadoorie?
Kadoorie owns the Peninsula Hotel in Hong Kong and various other business. So.
Yeah. Just a spectacular study and a fabulous presentation. I'm going to suggest that we don't take any questions at the moment. Wait. So if you forgive me for that. I will ask you one question. Was that a painting of Richard Doll in the background? Yeah. My prerogative. Our next speaker is Dennis Frost-Degnan from Harvard School of Population Medicine in the Harvard Medical School, Department of Population Medicine in the Harvard Medical School. Dennis has a long experience, you can read about it, and you can Google him, of working with a range of data types, given that this is a big data session. Today we've asked him, because of his work with insurance data and looking at emerging insurance programs for health in low and middle income countries, to focus his wide experience on a discussion of that particular type of data. So we talked about when routine data are not available. We've gone to the other extreme of where we start to drill down with deep phenotyping and now omics data. We want to look here at the utility of insurance data. So Dennis is going to do that for us. Thank you very much indeed.
Thank you very much, David, and thank you to the organizers for inviting me. I'm going to be a bit different, I think, from the other presentations. Number one, in a session on big data, I'm not going to present any data. And second, I'm not going to talk about research. I'm going to talk about the normal functioning of health systems globally. And about the emerging use of electronic data. And there we go. So globally, and especially in high-income countries in the West, there's a deluge of hype about how big data can transform health systems. And if you look in medical journals or in trade publications, you'll see the promotion of the creation of very large data systems from using routine data from health systems in order to be transformative. And what types of data are we talking about? Really, they're coming from two sources. One is data that are generated in the process of routine care, clinical data, because it's generated during care. Their clinical detail is rich, but it's quite difficult to standardize, and it's captured in many different ways in data systems. Another type is, and the type that David mentioned that is generated by insurance systems is typically called administrative data, and it's generated either through the process of paying for care or through the process of supply. So pharmaceutical data is often data about pharmaceutical uses available through supply chain information. And those types of data tend to be much more standardized, but have much less detail. What if people think that these types of data might be able to actually do in health systems? The list of possibilities is enormous, from using the data about practice to improve practice and to improve the clinical effectiveness of care and also efficiency and cost effectiveness of care. To do disease surveillance, to be able to look at information that's generated to surveil both infectious disease and also chronic illness, or the safety of medical care, the safety of pharmaceuticals or different types of medical procedures. If you collect enough of it and have it over time, it's possible to do very large-scale, long-term epidemiology. And if you link it to biobank data or other types of information that you might be able to obtain and link, it opens up entire new possibilities of epidemiology. Or to build very large databases and then just begin to explore and mine and find relationships that weren't able to be suggested because of either the rare occurrence of outcomes or the noise that can populate large data systems. So what are some of the advantages and limitations of these kinds of health system data? Number one, they're there, and so there's no additional cost to collecting them. There's a big additional cost to assembling them, but the potential for generating very large samples of data over time is enormous. And there's no recall bias as there is when you're surveying people about events that happened in the past. There's obviously observation bias, and we'll talk about that in a moment, but to the extent that these types of information can be collected prospectively during care, it's possible to assemble then information that is subject to one less type of bias. But there's lots and lots of limitations, and the biggest one really, because they're not collected for research, is that they're dirty data. The data quality and consistency of the process that's being used to capture them, of how they're recorded, of how they're then assembled and coded is very problematic. The classification systems that are used, how you classify illness, how you classify pharmaceuticals, how you classify socioeconomic status or any of the other data that you might be able to obtain from such a system is problematic. And because many of them are generated in the process of payment, how things are coded, because coding determines payment, what you call what you're doing in order to maximize revenue is problematic. There are typically huge gaps in these types of data systems everywhere, including in Western countries, but especially so in lower income countries. And also, systems evolve over time, and as systems evolve, the quality of the data and the way the data are coded tends to evolve as well. So understanding natural evolutions in systems. Then when you try to put them all together, you have that compounded. You know, the linkage between sources is problematic. Organizations and individuals, for that matter, own the data, and so data ownership and privacy and governance of the data become very important concerns. Protecting identities, and especially because these data, for the most part, have been collected without consent, is really problematic in many countries. And they're, by their nature, limited in their comprehensiveness. The amount of clinical detail that's available in the different types of data is variable. And the kinds of things that you really would like to understand in order to be able to explain what you see are often poorly recorded, like what's the system that's caring for this person? What are the surround? What are the contextual variables? And what do you know about this person other than age and gender and the very simple kinds of predictive things that you can capture in a routine data process? So now I'm going to shift the frame a little bit and talk a bit about what's happening in much of the rest of the world. And one other big driving concept that is active globally, and that's this move towards universal health coverage. That is a driving force that's pushing countries and institutions in a certain direction as we try to expand the right to healthcare and access to healthcare for everyone. I'll talk a bit about the Joint Learning Network, which is, this is their homepage, and there are the countries listed that are part of the Joint Learning Network. It's a network that links together emerging universal coverage programs, often captured in the form of insurance systems, public and private insurance systems, to try to learn together about how to do what they do in a better way. And one of the things that they're trying to learn together is how to structure their data resource in order to maximize system learning. And this is the next few slides are going to be difficult to see in detail. You're certainly, I have the website references, and I think you'll be given the slides afterwards. But I just want to explain a bit about what they're trying to encourage countries to do. So in this case, they're recommending that countries assemble the data of the two types that I mentioned, data from the insurance systems in blue, data for care delivery systems in green, link them together in various ways, create a governance process to be able to manage those data, and then have a layer of access to those data from a variety of different types of individuals and institutions, from the people themselves who are being cared for in the systems to health providers who can learn by looking at practice and the kinds of information that they can get, to policymakers, and then finally to researchers. So how does this look then in reality and what's going on? I've picked just 3 country examples because they illustrate 3 different kinds of approaches. Korea has probably the most evolved system globally that's built entirely from insurance system data. They were one of the first Asian countries to obtain universal coverage, and during that process and over time, they've assembled an enormously rich insurance claims database that's used for a variety of purposes in their system, and increasingly for very detailed pharmacoepidemiologic research and other types of research. And you can see that they've assembled processes in one organization, which they called HERA, the possibility both of managing payment, which is why they collect the data in the first place, but also then availing of the data repository to do research and also to do system learning. So Korea has, the creation of this system and the creation of their insurance program had almost brought down a government, has created many problems over time. Providers have resented the fact that they're being surveilled in the ways that they are, but it's created a very rich resource for system development in Korea. I'm going to talk a bit about South Africa. This is very new, actually. This is their development path in this area. And I'm going to point out, obviously there's a lot of detail in there, and they have big plans for how they're going to create a centralized repository of all of their information. But I'm going to point you to the lower right here. As many of you know, South Africa is a 2-tier system, and many of their health institutions have paper records, if at all. And they have an enormous problem of saying, well, we have a very advanced care system in parts of our medical environment, and we have a very underdeveloped care system. What do we do to reach the pathway that we're going to? So they're trying to work within their the paper-based medical record system and say, what of the data that exists in that system is it worth extracting? What can we trust enough to be able to go through the process of extracting the data, coding it, and inserting it into our longitudinal pathway? So this is a challenge that most African countries, many low-income countries or mixed system countries are facing at the moment. What can you salvage from what exists in moving towards a common pathway? And finally, I'll talk a bit about Brazil as an example of a country that's a very well-developed data environment, but also has begun to think about ways to integrate. And in the green are the two types of data that we're talking about, or actually one of them. That's the data from their medical services system, hospitals and primary care systems. But they also have integrated it with mortality data and birth data in the orangey box on top, which again, they have very evolved systems for. In the blue box on the right, their institutional data, the environmental contextual factors that I mentioned, what they know about healthcare facilities, what they know about geographic differences in socioeconomics and so forth. And then in the yellow on the bottom, very specific program-oriented information that exists in rich detail. So they've created, I'm not showing you any of the data from it, but they've created an environment that makes it possible to do very sophisticated research now in the Brazilian context. So how can I summarize? There's large amounts of routine data out there available for many different kinds of use. Most importantly, for my work and why we do what we do, it's for policy analysis, how to make the system function better, but also for observational types of research, for data mining applications. Many middle-income countries, I showed you examples, and some low-income countries are really moving far along the pathway now towards creating these big data systems for a variety of reasons, encouraged by donors and by this move towards universal coverage. But they've got a lot of challenges to overcome. They have the advantage because they started late of learning from a lot of the architectures of big data environments globally, so they can build a fairly modern, advanced architecture at the beginning of their process. Lots of technical and human resource and cost barriers. And finally, huge problems in data quality and validity. But as they learn, as we've learned, which of the data that they're able to trust, they have the potential to join the global movement towards big data. Thank you.
That's great. Thank you. I just don't know anyone else who could have just encapsulated so much information about what's happening internationally in such a short period as Dennis. Again, I think we're really doing quite well on time. I really want to thank all the speakers. I think we're going to have a session where we bring the speakers back up on stage, so we'll let you get away for the moment. One of the ways that what we still call developing countries and technological development is access to mobile technology and mobile communication technology, and in a sense allows a leapfrog over our copper wire-based systems of the past. And this leads to people using media that we couldn't have dreamed of 20 or 30 years ago. Our next speaker is Rumi Chinara, who is from is working at in Boston at Boston Children's Hospital and Harvard Medical School, but I think is maybe about to move to NYU. You're going to come to that, okay. Rumi in particular has been looking at the value of social media. So this is our final cut of the big data scene, is to look at the use of social media. We're all involved in some way, whether it's exchanging photographs with our families or tweeting, which is going on the wall off to your left. This is a potential resource for information about health, in particular outbreaks of ill health and outbreaks of epidemics. So Rumi, I'd like you to come forward and tell us more about that. Thank you very much.
Thank you. All right, so I chose this image and this title. Well, actually, first of all, I want to thank the organizers for having me here and being amongst this very distinguished panel. And so as David mentioned, I'll be talking about something a little bit different. I chose this image and this title because, we've been hearing the theme of connectivity a lot during the last few days. So whether that's connectivity between health and what are traditionally siloed other fields, whether that's connectivity between us around the world, how something happens in one place, it easily resonates in another, and also connectivity by the internet and all the downstream effects of that. So today I'm going to talk a little bit about how we can turn some of that connectivity into connection. So this is a stock price of a Chinese pharmaceutical company, and pardon my pronunciation, but it's Guangzhou Banshan Pharmaceutical. And back in January of 2003, the stock price for this company dramatically increased. So they manufacture this herb, which is commonly known to alleviate symptoms of acute respiratory infection. So if I have something like a cold, I'll buy this herb. So back in January 2003, the stock price increased. And what was happening on the ground were a lot of school kids were getting sick with something like a cold or a respiratory infection. It wasn't until March that this was then later identified as a new pathogen and named SARS. More recently, this news article was picked up on March 14th of this year from a newspaper in Guinea. If you can read the French, you'll see that it talks about a fever of unknown origin. Didn't talk about specifically Ebola, which is what it was referring to. Also, to H7N9. So the first case confirmed in a human. This was in China. Where was it reported? It was reported on Weibo, which who knows what Weibo is? It's a Chinese version of Twitter. And then later the hospital confirmed this. Where do they do it? Also on Weibo. So just to give you an idea of where information is flowing these days. So it's not just as simple as this, though. It's not just as simple as sitting at our computer and trying to find keywords or looking for mentions about a particular disease. We heard yesterday from Dr. Butta about how there's a lot of unknowns in terms of social determinants for disease. We heard from a student yesterday evening about how we're not capturing the community, the local, the patient voice. And so there's a lot of open room here for understanding things that we don't get to by some of our traditional data sources. I'm not one to speak about Ebola, but I'll let Angelique Kidjo, one of my favorite artists, she wrote this piece in the New York Times. It was very well. I appreciate it a lot. So sometimes not everyone can go in to see the doctor because of access or other reasons. And so there's a need to capture information outside of that. So I want to dive a little bit deeper into that idea. So public health, our traditional public health systems, we know how this works. We're the public. We report to public health practitioners, like physicians, healthcare workers. That information, along with laboratory confirmed information, very, very nicely done, is reported to ministries of health, and then on to larger bodies, decision-making bodies like the WHO. But with these new tools, we view that information can flow a lot easier, maybe a lot quicker between these different bodies. And that information flow can happen both ways. Of course, every data set has biases, and we have to constantly, as scientists, as people, we have to be able to understand that. There's biases in terms of spatially what's happening. So here there's two pie charts. In the middle is data from the WHO's disease outbreak news for a 3-year period, 2006 to 2009, showing where all of the outbreaks were that they reported on. Of course, a lot more in certain areas than others, and that's going to be influenced by where their field sites are. what was captured in the news for the same time period from Health Map on the left shows a different picture. And so that's also going to depend on where the news outlets are and who's covering them. Also temporally. So this is a picture of what happens in the United States in terms of influenza. So this is data from the CDC's Sentinel sites. This is a group of doctors' offices and hospitals that report weekly the proportion of people who come in with influenza-like illness. So it makes sense. Consistently over a 10-year period, that starts increasing in the fall. But then at certain times of year, consistently, this drops off. So that's American Thanksgiving and New Year's. So at these times of year, people don't come in for things like influenza. Maybe it's too mild. Maybe the disease dynamics change with different patterns in people's habits. So we use these figures to motivate this paper, why we need crowdsourced data in infectious disease surveillance. So even in places where there is relatively good healthcare infrastructure, people don't always go in to see their doctors. The social environment. We've had a rapid change in the disease landscape around the world. So over the last 10 years, the prevalence of non-communicable diseases has increased dramatically in a lot of countries. And so that indicates that's not just genetics driving these changes, there's also environmental risk factors. The built environment has typically been more easy to measure, but the social environment not so much. It's difficult to know who's influencing you, what they're saying. Nowadays, maybe there are other ways to measure it. So I want to move on to 3 examples. So my interest is in disease surveillance. So I'm going to talk about 3 different examples, again, to give some ideas about how maybe we can complement some of these gaps and fill in what we know with other types of information. So Go Viral, it's a study that we're doing to investigate what types of specimens we can collect at scale from the population. And so in particular here in relation to respiratory infections, influenza, cold viruses. So for anyone who signs up, we send them a couple tubes and we ask, if you're sick, give us your spit in the top tube, and yes, give us some of your snot in the bottom tube and send that to us. And so we can get we then test them using the latest molecular methods. We can get a local picture of what's actually circulating. Is it flu? Is it other types of viruses? We also ask people to report their symptoms on a smartphone app or on the web. And how does the data look? It correlates in time with what the CDC is saying. So sometimes there's not such a good picture spatially of what's happening in terms of disease. So on the left is data from the Malaria Atlas Project, a project out of Oxford, where they've aggregated all the available information in regards to malaria from the literature, from other clinical studies. The areas that are gray of this risk map are uncertain risk, so there's just not enough data. And it's also pretty homogeneous in areas like in Mumbai, which is highlighted in that red circle. But if you look at the population map, on the right, there's people all over. So we're taking advantage of this, trying to start fill in and get a little bit more rich data about what the disease incidence looks like using Amazon Mechanical Turk, looking at neighborhood to neighborhood within Mumbai and other cities around the country. And our social environment. So we spend a lot of time online these days. How do those interactions represent what's happening in terms of our health? We looked at activity-related interests on Facebook. I heard that size matters. How about 1 billion people or more who use Facebook? Of course, TV is known in the offline environment to be related to obesity. And so we looked at proportion of people with more television-related interests, neighborhood to neighborhood within New York City. So you can see that on the map. And then how does that compare to the prevalence of obesity, obese or overweight people in the same areas? And so, of course, this is just a cross-sectional study. but we found that these actually statistically, relate. So just to kind of get the juices flowing and get you thinking about other types of data around the world. Talked about a lot of different data types that are facilitated by probably easier communication via the internet, but also thinking about how we can validate information at scale, get a more specific idea. Talked about some of the ways this can play in spatially, temporally, and within the social environment, and turning some of this connectivity into real connection. And all of this work was done at Harvard Medical School with a great team there at HealthMap and the Children's Hospital Informatics program. But I'm moving to NYU in the Global Institute of Public Health and Computer Science. Why am I telling you? Because I'm looking for outstanding students and postdocs. So anyone interested in this type of work, I'm looking for you. So please send me an email, and of course, questions anytime. Thank you.
Let me just stay up and have a seat. So we've covered a really express tour of a version of the range of data that are being generated internationally. And notice how many of these examples and how much of the data we've been talking about are coming from low and middle income countries. Start to reflect a little bit, perhaps, on are we making the same progress in the countries in which we live? I think there is more radical, innovative thinking and more technological development and more use of data, more generation of data. There's potentially very interesting in some of our low and middle income country partners. I'm going to ask our speakers to all come up now to the stage without introducing any excessive formality. I'd be grateful if you could come up and join us, because we're going to have just a period of questions. We've not taken questions after each of the individual presentations, and I got the sense that probably we covered a lot of ground, but I got the sense there probably were some questions from the audience, and we cut off those opportunities. So I'm going to, rather than for me to try and synthesize the information or start the process, I think I'll just open it up to discussions. So the questions can come from the floor, obviously, but the questions, I think, can also come from the panel of each other and the members. But I think we've got Russ Upshur going to do the first one.
Thank you. So I'm not even going to ask a question about ethics, but about analysis. So we saw nice pictures in the Chinese sort of data bank study. You talked about multi-omics. I'm curious how what the analytic strategy is across the different omics, how you're going to manage collinearity amongst them. Our typical statistical tools and 95% confidence intervals, et cetera, aren't going to do the work that they usually do with these humongous large data sets. So how much investment has been given to the statistical approaches that will be tested and worked out so that we can actually make sense of these large volumes of data? Because the other issue is that two of the omics in particular, the exposome and the microbiome, and there's 48 omics now that I've counted at last time, change almost on a daily basis. So we've got a huge, not just temporal day-to-day, but seasonal variation. So there's multiple sources of variation that need to be accounted for in these transomic models. And just what sort of thoughts you've given to putting this all together in some sort of coherent way?
I think this is an excellent question. I think this is the issues we're trying to deal with. I think, at the moment we're still managing with the conventional sort of statistics, which I showed Cox models, but very soon we'll start to get a lot of multi-omic data. So we've been trying to set up some collaboration with not epidemiologists, not with the medical statistics, but also with big data, Stanford, and with Oxford machine learning. They're working on the machine learning, Rolls-Royce engines. So I think we have to be sort of innovative in terms of collaboration using new tools to deal with. I think it's a huge challenge, but I think it's opportunities there as well. So we have to reach out. So that's what we're doing at the moment.
I think take a comment or question from Prabhat, and then I think it's
just in follow-up, I think the main constraint actually is having large enough population-based studies the Wellcome Trust efforts to create open source shareable ways of analyzing genomic data are certainly going to be transferable in some ways to at least some of the multi-omics, at least in terms of signal to noise. It involves engaging computer scientists as well, and certainly in Toronto we've got a very strong computer science community to do so. But the main constraint is simply not large enough sample populations. And if you think about, well, in clinical medicine, people still talk about Framingham results. But remember, that's 5,000 people. They ended up publishing 6,000 papers out of 5,000 people. And the amount of information that actually is relevant, for example, the relationship of blood pressure, is really out of date. So the main constraint is big studies, not so much how to analyze them.
Just one thing I forgot to mention, actually, in Oxford, actually, is an initiative to tackle the big data. We just established the Big Data Institute, funded by Li Ka-shing Foundation and the government. So this brings together sort of research groups across different disciplines. So that's another initiative going on.
OHIP diagnostic codes, Ontario Hospital Insurance Plan diagnostic codes, which have to be put down every time a GP sends in a bill request.
We collect all of those at ISIS. We have every transaction coded under the OHIP process and linked to all of the other broad data sets. So the CIHI data sets, the discharge abstract databases, vital statistics, registry data are all linked in Ontario. Howard, I think you're next, then we're going to go across.
Thank you. That was a fantastic update on two of the largest epidemiology studies in the world and these creative uses of administrative data sets and also social media. This is in the context, this whole summit's in the context of planning our Institute for Global Health Equity and Innovation, and many of the themes that were explored during the summit were about populations that aren't studied well, marginalized populations. And here we've heard from low-income countries and high-income countries, but my question relates to within-country disparities. And I guess I would challenge each of you to reflect on what your giant efforts are missing. So for instance, in China, what were the recruitment strategies in China? Are there subpopulations of people who are not represented, either ethnic minorities or even the very large migrant populations that we have actually studied in some of our centers? Shanghai has about 18% migrant workers who don't really get reflected well in administrative data sets, for instance. How does that might relate to administrative data sets being created out of hospitals? Who has access to social media? Obviously, people who don't have smartphones or PCs. And even in India, how the Million Death Study, whether it might in fact reflect some of those subpopulations as well.
Same first, sorry, Dennis, did you want to respond first then?
One of the, speaking from the point of view of assembling administrative data, one of the driving concepts is to, reflecting the name of my department, I suppose, take a population perspective, and having a denominator in a lot of this work becomes crucial, because if all you have is a numerator, it's very difficult to make inference about real rates or trends in rates. So having some method, either a geographic method or in the case of the administrative data, a payer who is responsible for an individual, and then learning the processes that prevent you from observing the events of interest in the database of that institution. So insurance systems are the primary way of trying to now globally assemble that type of a denominator. The issue that you mentioned is very crucial. Who gets excluded? Who doesn't avail of an insurance system, even in universal coverage? The rates of coverage in the best performing countries are 95%, 90%, and there are certainly populations that get excluded. And even more important, there are events that get excluded, people who bypass and use the system in ways that are unpredictable. So learning about the processes that are causing missing data, I think, is really a crucial issue in all of this research. We all are missing information, and learning about why and what kinds of information is crucial.
Fine. We're going to make this, no, with 2 more questions. Thank you. Yeah.
So I was wondering, a lot of the diseases that we study, it's been realized that there's this concept of the exposome, which is the lifetime exposures. And so a lot of the data that you're talking about, at least to me, it seemed that it was a snapshot in time. And I'm wondering, what are the plans to collect this data longitudinally? Because if you look at things like the Dunedin study or the Farmingham, they've been collecting this for a long time. And so it's not just at one time, and they've learned a lot from that. And so I'm wondering what the plans are in each of your studies to do that. Thank you.
Well, I'll add that the Million Death Study is a series of cross-sectional annual surveys on mortality. And yes, retrospective investigation of the causes of death does need to be complemented by prospective studies of the kind like Kadoorie, the UK Biobank. They're complementary. But you have to also think, well, at the population level, big important risk factors can be documented both through retrospective and prospective studies. So you need both. Obviously, organizing prospective studies is an order of magnitude more complex, as Zhenming will attest. It takes a long time to get those right, but absolutely both are needed.
Final question. Sorry.
Sorry, were we all going to chime in? I didn't know.
Yeah, please do. Yeah. Go for it.
I would say that's a great question. And from my perspective, there's both, it's kind of two-sided. I think, of course, engagement directly with someone to get a longitudinal view is another challenge that wasn't exactly addressed in any of what I've shown. However, the platforms that I've been speaking to actually provide maybe an easier way to get that kind of continuous digital, a lot more easy, less labor, time, cost-intensive way to keep connected with someone over time.
Can I just make one quick comment? As ideally, big prospect study would be good to to conduct periodically, but I think that's not feasible for study like 500,000. So what we do is actually a random sample. Another thing is actually now we have a genetic tools, which is very powerful. This really can help tease out causality from sort of false positive results. I think I'm going to share some results in my second session to really highlight some sort of promises that actually genetic can bring into identify some causal exposure.
Thank you. Final question.
So a lot of discussion has been about aggregating data and creating a repository that scholars can look at. But the other issue is how can one disaggregate data? How can one keep data as opposed to information or entries into various columns and so that the individual's data can now be reaggregated with their permission. But even when there's floods or revolutions, people carry their vaccination records. They carry some kind of record of what happened to them, just as a mnemonic. So what about creating technology that will allow people to carry their records with us? We've talked about personal health records, but we haven't really done it seriously. We haven't really enabled. In Katrina, they tried to give out little USB keys to individuals, but that was considered too disruptive. So I think we have to move politically to allow people to own their data, regardless of whether they're in Pakistan or Canada.
Interesting question. So, Dennis, I think you raised your hand first.
There are actually examples of that. Again, I'll use the insurance system analogy, and it was a method of fraud prevention, actually. But Jordan and other countries as well have people carry their data on a chip card, so that when they go and receive a service, the person who's providing the service can be sure that they're going to get paid for it. But then it also allows them to learn about the other services that have been given, because there are limitations on how much service. So that kind of a method, is an approach that can be exploited for different purposes. It gives people actually ownership in some sense of their data, but the person who's carrying the chip card has no access to the information. So I think really what you're talking about is twofold. One is how can we empower people with their own information, and then how can we be sure that that information is available for research or for other purposes.
I wonder if I could ask one final question to Rumi. This is fascinating, the way data can be generated from these social networks. Are authorities going to pay attention to, have you got evidence that take it seriously and might act on it?
Yeah, just from my own work, I would say anecdotally, I work very closely with the Massachusetts Department of Public Health to both, reflect on what are important questions to be asking, what can be useful in their own public health practice, as well. Health Map, which is the group I've been working with, anyone can go to it, healthmap.org. It's a real-time picture of infectious disease events garnered from news media. The WHO uses it every Monday morning during their meetings because that's information they don't get through other realms. So there's some anecdotes for you. Just mentioned for the last gentleman, Open Humans Project is in this realm. I don't know if you've heard of it. It's also based out of New York to give people ownership of their own data, but also make it shareable more easily for research and other purposes.
Thank you very much indeed. I think we'll give some recognition to the four speakers. We're going to give you a break. 15 minutes? I think 15 minutes. Please come back. We're going to do a deeper dive into two examples. Leslie Roos, who's with us, is going to look at examples of use of social and education data in Manitoba, and we're going to take a deeper dive into the biobank linkage data. Thank you very much. See you in 15 minutes. Oh, right, and Laura. Laura.
do I tell people, or how do we?
No, and they won't want to. It doesn't happen too much when you get old, trust me. Even under the sun. I don't remember when last summer.
Já falar, se eu perder esse trem, que sai agora às 11 horas, só amanhã de manhã. E além disso, mulher, tem outra coisa.
Good afternoon, everyone. We're going to start in about 2 minutes, so if you could take your seats, that would be greatly appreciated. We'll get started. Thank you. Good afternoon, everyone. I'm Laura Rosella. I'm from the Dalla Lana School of Public Health. And I'm very pleased to welcome you back for the second half of the big data session. As David mentioned, for this last component, we'll be taking a deep dive, so to speak. And really what that means is we wanted to allow the space for a deeper discussion on what big data actually means and how we can use it. And we've picked two distinct examples to do that deep dive, and they're quite distinct. So the first one is about routinely collected data, which we've heard a bit about, and really about linking both social and health data, which is really critical to some of the themes of the summit. The second example is related to biobank data, and we'll welcome Dr. John McLaughlin from PHO to moderate that session. Another way to think of these two data sources would be wide data versus deep data, both very important for health and both deserving of a good discussion. So it is my distinct pleasure to introduce the first speaker, Dr. Leslie Roos. He is a true pioneer of health services research and one of the most highly cited Canadian scientists. Dr. Roos is a distinguished professor from the Faculty of Medicine at the University of Manitoba and a member of the Academy of Sciences of the Royal Society of Canada, among many other distinctions that you can read about in his bio. But the most important piece of information on Dr. Roos that I'd like you to know is that he was a founding director of the Manitoba Centre for Health Policy, along with Dr. Nora-Lou Roos. The MCHP, as it is known, is a very unique institution. It was one of the first data-based policy units of its kind in the world. So it was really transforming the way we think about routinely collected data and how we use it to change policy. So almost 30 years ago, the Rooses had the foresight and dedication to build a data repository that links all types of both health and non-health data, and in particular is quite unparalleled information created by linking health, social, and education data all at the individual level. So because in Manitoba, healthcare is covered under a universal single-payer insurance system, the data are truly population-based. And what makes the data so powerful is that they can be linked at the individual level over time and with each other through family structures. So researchers have used this data to show the health impact of social factors. For example, the impact that a mother's education has on both the health and the educational attainment of her child. So generational impacts. In addition, with family structure information, Dr. Roos has led a number of sibling studies. And these studies can be used to tease out a variety of social and environmental influences on health. So Dr. Roos will share briefly his perspective of almost 30 years of experience with this type of data, including both the challenges and the opportunities, so we can start to unpack what this means for these data systems being set up now all over the world. And importantly, we can start the discussion for how this can underpin the policy actions that are needed to make the health gains we've been talking about at the summit. So please welcome Dr. Roos.
Thank you, Laura. It was actually about 40 years ago that Nora-Lou came back from a visit to what's now Manitoba Health, saying, you know, there's some really interesting stuff there that they're only using to pay physician bills with. And so that's how it all started. Well, it's a great pleasure to be here. And I'll just start with a couple of pictures. This is a bit of a generational picture. How many people know who's there? You don't, just any hands? I don't need a tweet. Oh, no hands. Oh, come on, there's some people here over 50. No, that's Freeman Dyson, supposed to be the smartest man never to get a Nobel Prize. He and Richard Feynman used to go on road trips, which I can only imagine the two of them together. He's 90-something now. And so he talks about the technology and the fact that tools really are important, and they are important for science and for changing our perspective. Now, the other person here, you probably will, many of you will recognize. I happen to be a Bruce Springsteen fan, but the human touch is of incredible importance in working with governments, and it's perhaps useful that in our family, perhaps I was more like this and Nora Lou was more like this in terms of having the human touch in working with governments. Now, if I just present the data, which is really of great interest, everything is linkable at the individual level here, and up in the corner here, it doesn't matter. Up the education, Healthy Child Manitoba, immunization, social housing data sets are ones which have become very popular lately because they're quite new, difficult, in our case, to get access to. Each data set really has its own story in terms of access. The cancer cure data, you see the dotted line, that was over 20 years to get access to, of smiling persistence is the term which we use. There are, what's been important to our development, and Manitoba is a small province, 1.15 million people. We have 5 ministries involved with these data sets. And there is a Healthy Child Initiative, which puts all 5 ministries together around the same table, talking about what's important. So the work with the ministries has been incredibly important. The other small province advantage is in at least 2 of the ministries as of, well, I don't know what's going to happen in Manitoba politics, but at least as of a few days ago, I'd coached a daughter of someone high up in the ministry, and somebody else had a child who was taught by in elementary school by somebody connected with our center. So the human touch seems to be particularly important. I mean, luckily they thought I was a good coach. I don't know what would have happened if I'd kept their daughter on the bench the whole game. The other thing here that I think is important that I'll get into, there are things that are easy with databases and things that are hard, if not impossible. And it's a continuing question as to what's easy, particularly for interventional studies, which are getting very popular. Things like propensity scoring is easy, family work involving siblings is easy, finding one's neighbors or finding study members' neighbors for control groups is easy. And the whole bunch of other things which I would love to do, but they're really hard to do. And you just have to, be thankful for what you have and what you have access to, because we don't have things, sometimes we have problems getting mother's education. Other times we have problems with using small area variables when people would like us to use individual variables. So there are many things which we have to kind of restrain ourselves as methodologists about. Now, the thing that's really important here, let me just go back. Okay, we have a thing. We have a repository, which I've mentioned, and it helps us generate the following large number of cases, we can use for all kinds of studies. Now, large may not be large by some of the examples which we've seen earlier today, but certainly large by the Framingham study. In fact, I have a friend who talked about one of the studies from the US studies of pre-kindergarten, and he said the N was 150, and I have 150 term papers that over the years have been turned in to me. So again, time, space, and individuals and families are really important here. Now, the collaborative model where you're working with governments is one which I think we have to continually pay attention to. The relationships here are very different than I teach a course on great research, and we look at the Framingham study and we look at the panel study in income dynamics in Michigan, and a large chunk of their relationship building has to be done with their respondents to keep track of them, to get them to collaborate, to cooperate, and so forth. Our relationship building has to be largely with government. We have to be very engaged with them. But at the same time, of course, we can bring in new data sets one by one and work with them and just realize that the relationship building is going to be incredibly time consuming. The challenges are many here, and as we've talked to people around the world and also in Ontario, each site has its different problems around access, quality, and relationships, and then we're really prone to complain about it. And this was one of the important human touches, is try to keep us thankful of what we have rather than what we don't have. The population registry, if it's at all possible, people have spent a lot of time trying to reconstruct in Australia, reconstruct population registries when they're not available, because they're both important for standard area-based denominators and for particular studies. It was particularly important in education, where school results of testing in schools didn't reflect the I think it was about 20 to 25% of our high school age students who either were not in grade 12 or didn't bother to take the tests. And as you might imagine, these were students in the lower income quintiles, and it really changed the results. So a lot of effort has to be directed here. The data management issues are important, and I've talked to people from various substantive fields about data management, and my advice for the informal stuff is just get it up there. Put flags on it, if parts of it might have to be passworded, if some software code gives too much advice, too much help to someone who wants to, or who might want to break into the system. But you can start small now, and putting anything up is better than nothing. A lot of appendices or notes contain incredibly valuable information that we need to share. We have local challenges. In the interest of time, I'll skip the ones who are which have been resolved. The marital status issue, with social change and change in data collection, we're in real danger of losing high quality marital status information. I talked to University of Toronto students last year, and I said, I don't care about your personal life, but please go down, and if you get married, please register. Please let ISIS needs you, and I got a good laugh out of them. But and then the non-standard measures I've always mentioned. Okay, now the human touch, we've talked about communications. We have a joke about smiling persistence. It took like 4 years and 364 days of smiling persistence in a 5-year term for the deputy minister to give us access to the education data. Patience and paperwork, and I'll spare you, I've got some favorite paperwork stories, but I'll skip. I think everybody does. Things that just seemed just such a little thing, and then it just blew up into a privacy, confidentiality, new proposal necessary. So we have to be sensitive to this. Now, I do have a couple of lessons for people. Save the rants for your partner, spouse. I think, you know, this really is important. And not public rant. And the second issue is important. Try to abide by the rules, even if they're, if sometimes they drive us crazy. And I've only had to use the clueless defense once, but you want to keep it for major screw-ups. So thank you very much.
Liz, do you want to stay up?
Oh,
sure, just for a moment.
Okay.
So we have a couple minutes for questions, and I also want to thank you, not just for your talk, but the foundational work that you and Nora Lu did that really enabled the reason why many of us are here today. So thank you for that. Just invite anybody up if there's any questions of clarifications, any questions about the Manitoba Centre for Health Policy. I'll start off with a question. And this is not just for Les, but perhaps for the audience. We've talked a lot about different types of skills. So in the earlier session, we heard analytics. Do we have the analytic skills to analyze these omics data and different layers of data? Can we calibrate our measurements? But you talked about the personal touch, and I wonder what you and others think, you've mentioned this to me, about the role of data partnerships, and if we need to start dedicating some of our resources specifically to facilitating those difficult conversations with government, privacy, confidentiality.
Well, I think it's essential, and it number one takes a personality who might well not be the hard-charging research type A personality to deal with this personally. I mean, I know I have my real limits in terms of developing relationships, and people have to really think about what they're good at. The difficulty is, and I know it's a problem in the Toronto atmosphere, is how do you get credit for it? If you're on the academic side, it tends to be undervalued unless the administrator, the dean or the provost has gone through, seen what people involved at places like ISIS do to build relationships, and it's absolutely essential.
David.
Really more of a comment, Les, and following on what Laura said. The work that you did with Nora Lu, and I know this has been celebrated a number of times. Yeah. I was at the 25-year celebration or 20-year celebration of the Manitoba Centre, and the praise that was heaped on you. But I want to just point just how important it was to us at ISIS to follow the work that you and Nora Lu did. I was CEO at ISIS for 6 years and stepped out of that role last year. And always I felt that we were chasing those benchmarks that you'd established in terms of linking data. I really want to point to the importance of linking social and education data to health data. That is, one of the big leaps, and has been one of the big leaps for us. And I think that we're getting there, but it's really, really slow. It's different legislation. The people we're dealing with are in different ministries. They're not so familiar with the idea of sharing data. They're naturally very worried about privacy. They see these rather aggressive health researchers coming along, knocking on their doors, and they are anxious. I think we create anxiety, even when we're trying to be nice. I'm not sure that health researchers are that nice. So I may just ask you to comment a little bit more on your experience on that. The other thing is the time it takes. We've now been going, I think, for 3 years, 2 to 3 years, negotiating the access to education and better social services data. In the case of First Nations, it's been more like 4 years we've been working on it. We have got good agreements, and you have to build that relationship. I think that's the key thing, and really just reinforcing the points you made, that building relationships are essential to this. These data won't just arrive as a result of an email or ticking a box or filling in an application. You have to go and sit and talk to people. You have to socialize. You have to spend a great deal of time understanding their concerns and allaying them when you can, or changing your practices when they need to. So it takes a great deal of time. Just any more you could advise people who are trying to do this sort of work?
Well, I was thinking back about what I forgot to mention, and we have a deliverable process where our funding from the government is negotiated with 5 things that the center has to deliver every year. And it's a long process among the ministries and interested groups like First Nations groups. And it's a long process. People have, what's good about it is we may have 20 things and they may have 20 things. So there's a learning process about what is and isn't possible, and why is this thing which is on the ministry, high on the ministry's list, we don't think we can do so well. So I think that process, that deliverable process, is again very time consuming, but I think important for new people when the new data set comes in, for them to think in a year or two after they take this step, which is forward thinking, seen as a little bit dangerous for them, someone's going to get a product which they can use in their ministry. The most dramatic example was the education example which I mentioned, where they had no idea that their real dropout rate was so high because they didn't have any statistics on this. So, and then they put in a number of, they actually almost, something like resurrecting a truant officer and so forth to deal with this. So not only was the product delivered, but the people who took the chance in the Ministry of Education got positive reinforcement for delivering it. And I think that's very important.
I think that's an excellent example and an excellent way to close the session. And thank you for this first part of the session. Thank you for really giving us a reality check, I think. We've heard some really fascinating results in the first session, some exciting results, some exciting graphics. But I think right now what we've done is taken a step back at just what it takes to create these data and the potential influencing policy in the way that Les has described. So thank you, Dr. Roos, and we'll call upon Dr. Chen for our next session.
Should I stay or leave?
You can come up. So we're moving now. We've talked about the routinely collected data back to the biobank data, and here we'll go into a bit more detail of that and hopefully have a bit more of a detailed discussion on what these data mean. I think we started getting into some of those issues. So welcome again, Dr. Chen.
Thank you. Good afternoon. I think I agree entirely with the quote made by a previous speaker. I think majority of revolution is driven by technology, by tool. I think this is the case actually, in my view, in sort of modern epidemiological studies. I think in my 20 years career as epidemiologist, to start with, we have a very limited amount of information, smoking, drinking, blood pressure. And now it's completely different situation, and we are completely overwhelmed by amount of information that's available or going to be available through electronic linkage or through large-scale multi-omic, to turn the sample into very sort of informative data. So I think in the context of China Kadoorie Biobank, I'm just going to mention a bit more about our linkage. When we first started the study about 10 years ago, in our original protocol, we didn't envisage this is possible. We said we're going to link to mortality, which is available in China for quite a period of time. But I think over the last several years, this is a reality. So in our study, we have now managed to link almost 100%. So we have a complete overwhelm, but it's opened up huge potential for biomedical research, not just common major disease, but also a range of other diseases which otherwise not possible to study or have not been properly investigated. Again, I'm just going to start with reminding ourselves the prospect studies, the unique characteristics, and also the need for big data, larger size, but also we need to have a very detailed disease phenotyping as well. That's also critical. Not just a big, crude, but also we need to get very detailed phenotype and disease subtype because especially I just want to use these slides, slightly different slides to highlight importance of big data and very detailed disease phenotyping. So this is actually study first, reported large-scale GWAS, conducted by colleague in Oxford, Pete Donnelly, and colleagues called Wellcome Trust Case Control Consortium. Bring together a couple of thousand cases and then common controls. It's relatively small by current standard, 2,000 cases and 3,000 controls, and they detect first one sort of hits, which is at the time very exciting because the first time use epidemiological approach to identify sort of a common genetic variant. This is a 9p21. But this is only one, and subsequently because of realization of the need for larger studies. So there's a huge effort international to bring together studies from different sort of from around the world to form a consortium. So this is called Cardiogram. Oxford, Cambridge, Harvard, many other big research institutions have been involved. So this is involve 60,000 and 130,000 controls. And suddenly, when you got the scale, you detect a lot more, including replicate some of the early hits, but also a lot more actually. But the effect size is still quite modest. But having said that, a lot of the signals are actually quite important for understanding disease biologicals pathways for drug discovery as well. So this is to highlight the importance of big data and the need for larger studies in genetic study as well. I mean, another things we just like to use the example to highlight importance of very detailed phenotype. So this is a paper we published many years ago, just looking at adiposity and esophageal cancer. Really depends on the subtype. You have a complete different association. For adenocarcinoma, high BMI is associated with increased risk, while for squamous cell, and it's complete opposite. So in a study, if you cannot distinguish that, and then you probably miss out two very important associations. So I think this is a challenge, especially in larger cohort studies. I think sometimes we're only based on the mortality, which you don't have this detailed information, but increasingly with the ability to link to health record, so you're able to get very detailed information from the clinical case report. So in China Kadoorie Biobank, as I mentioned, this is a three major data source for linkage. And the first is a mortality registry. I mean, it's been available in all the study centers for the last 20, 30 years. It's a not big issue. So we get standard death report almost on daily basis linked to our system. And in all the 10 areas we selected, they also have some kind of disease registry for cancer, ischemic heart disease, stroke, diabetes, with a varying degree of completeness quality, but at least can supplement mortality. But most importantly is the linkage over the last few years to have nationwide health insurance. this has completely transformed the study. So suddenly we're able to study not major disease mortality, but a range of other conditions as well. So this health insurance is something very new. It was introduced very recently, 2004 and 2006, but with a huge amount of government investment, now has almost universal coverage, in rural areas, in urban areas. And it was established not for public health, but for public finance. So collect very detailed information at the city or county level, population-wide, but using very standard sort of a procedure, code as well. So most of the data actually electronic. And you can have an ICD-10 code disease plus disease descriptions, as well as 2,000 or 3,000 standard sort of procedure code, treatment, examination, test as well. So it's a very good system. And but I think it has some other problems, as outlined by Dennis early on. And for some data not there, cancer histology, they got tested, but we don't have results. And sometimes you use a slightly different sort of IT system. There's a challenge in trying to combine them as well. But I think it's offer great potential. And so this is actually just a screenshot of some system in Chinese. It's one of the rural areas. It captured almost everything. On this side, you see, if you can read Chinese, there are 20 different items. The food they bought in hospital, test, special treatment, examination, etc. And also you have a procedure, for example, ischemic stroke, and also you can search, the examination, like whether they have a CT and MR as well. I think this is a wonderful system. Actually, it took us, we just began to realize only 5 years ago, and it took us 3 years to manage to persuade health insurance bureaus to give us access. And then now we have almost universal linkage, because in China, all 1.3 billion individuals in Chinese has actually unique national ID, 18 digits. So that's all available in our study. So we managed to use that to link to the database. So in our study, we have over 90% linked. So this is actually wonderful. So what we have got now is, what about the quality? So before we use that, we want to understand a bit better, actually, how good is the disease diagnosis, reporting, etc. So as a research project, we spend a huge amount of time actually trying to do event adjudication, whether there's a need to go back to hospital record, retrieve additional information, and to what extent the quality is acceptable for this kind of very detailed research. So over the last 2 years, we have done, event adjudication, very much like clinical trial, very detailed, go back to medical records, retrieve all the test results, and have a clinician independently adjudicate events. So this is 5 major diseases, each with 1,000 to 1,500. And overall, it's very good. We can retrieve most of the health record from the hospital. And for some disease, you don't need to worry much at all, like hemorrhagic stroke, cancer, and diabetes. The quality is very good. For some, you do need to go back. For example, with cancer, although diagnosis is very good, but lack sort of histology. So we need to go back, retrieve that. And for stroke, ischemic stroke, because of a very widespread use of a CTMI, 100%. So actually you end up with a lot of, we call it asymptomatic lacunar stroke. They found lesion, but actually they don't have a typical sort of focal deficit or symptoms. We don't really know whether they're a real stroke, so actually we need to go back as well. So this is quite useful to help inform our research strategies, strategy for collecting additional phenotypic information. It's a huge undertaking, but I think it's essential. So we have done 5, and also we are now extending to other disease. And for cancer, for example, we have decided, based on pilot study, to go back every single case where there's no histology to collect that. So we have developed a handheld device, download all the information from the database, and then send over to each regional center, and then contact hospital, seek permission, and then make appointment, and then go through, individual record, and then retrieve, and then actually collect all the additional information, including cancer histology, if breast cancer, ER, PR, some other sort of biomarker status, because that kind of information could be very important for understanding disease biology. And then, you can actually take pictures as well, so there's ways to independently adjudicate or validate as well, or write information. So this is a system developed specifically for the project, and now we have done 15,000 cancer cases, and also we have extended now to stroke, to cardiovascular disease, and hopefully we're also going to extend other disease. It's a huge undertaking, but also I think it's essential we define the study, whether this is a world-class study or not. So in terms of a linkage, this is what we have established. We have established a good relationship, permissions, and our system, it's very efficient. So every 6 months, we will be given the linkage data. So by 1st January 24, now we have the data available, all the events up to January 1st, 2014. So we have the first 6 months data of 2014 available in the database. So actually, this is very efficient. We can update, the follow-up data every 6 months. So overall, we have recorded 1.6 million hospitalized episodes among study participants over a period of 6-7 years follow-up, capturing almost every single disease. ICD-10 code is 3,500. I mean, this just shows number of 5 major diseases. Ischemic heart disease, 25,000, stroke, 36,000, cancer, diabetes, 10,000 to 20,000. But actually, on top of that, we also captured a lot of other disease. For example, we have 6,000 rheumatoid arthritis. We have 8,000 cataract surgeries. So actually, suddenly, we're able to do research not just a major disease, but also a wide range of other conditions as well. We also collected over 20 million procedure, treatment to test. I mean, we're still struggling actually to process, standardize. It's huge work, but actually potentially very useful, including insulin use, clopidogrel, aspirin, lipid as well. It can be very useful to validate diagnosis, but also for other research purpose. So I think, suddenly with this larger data set, with linkage to, electronic medical record, and the opportunity presented to become enormous. We can do a lot of conventional epidemiological studies to examine the association of smoking, drinking, blood pressure. But also we are able to do a range of other studies otherwise would not be possible. For example, we have a project started actually to assess the short and the long-term effects of air pollution. I mean, most of the previous study actually based on population. Now we can access, in addition to health record, all the monitoring, the air quality monitoring data across China. And then we can use satellite data, land regression model, etc. We can actually come up with some estimates of personal exposure. And then we can actually see to what extent the exposure is associated with a range of health effects. And after taking into account of smoking, other domestic air pollution. And also this provide a unique opportunity to do research on healthcare delivery utilization. Because China is undergoing rapid healthcare reform. There's no evidence, no data, no serious research because people cannot access. Everyone knows there's a huge challenge, a huge problem, wastages, unnecessary, inappropriate use of various treatment and a test. We need evidence. And with evidence, we can devise kind of intervention and assessment, and then come up with a policy. We can also use the data actually to inform drug development. I mean, this is something very exciting. I'm just going to show you one story about that. This is in collaboration with the GSK. This is a very interesting sort of a biomarker called LPPA2, which is a phospholipase enzyme carried on sort of LDL particles, and it has been implicated as a potential cause for cardiovascular disease, and with human evidence, with animal model. Interestingly, there's a function null variant in sort of genes coding that enzyme, which are present only in Chinese, Korea, Japanese, not in European, and which mimics the effects of treatment, which is under development. But it's a lifelong treatment. It's very complete. And so, if we can measure this genetic variant and link that with a range of health records, we can actually assess the efficacy and the safety of the treatment. So actually, and then try to confirm whether this drug is something useful, for the treatment of cardiovascular disease or potentially for some other drug. So we managed to get some funding from GSK, and we have genotyped 100,000 participants. Not, big sort of array. This is just targeted, probably just a couple of hundred SNPs, including that one. So now we can do a FINA-1 association study, one function SNP associated with a range of different outcomes, and to see whether it can confirm the expected association with cardiovascular disease, or whether you can detect some sort of unknown signals which may be relevant for drug repositioning or development or understanding treatment. I think we have a paper in the pipeline. This is still confidential. This is just used slightly different approach. But this is potentially quite useful, not just for drug development, but also for understanding, teasing out environment risk factors, the biomarker, whether this is actually a bystand or whether this is something causally relevant. So you can actually prioritize your research instead of wasting sort of billions of dollars on the complete false lead. You can actually target. And for example, we have started to use that approach. There's a lot of papers will come out over the next maybe 6 months, year, just based on 100,000. So this is a SNP we measure about 20 BMI SNPs. We have replicate. So this is for the FTO, which people know probably very well. This we got 10 to minus 41 zeros, a p-value. So absolutely extreme. And then because this is a set of genetic variants affecting BMI. Although for each individual ones, it's quite modest, but you can actually combine them to construct a genetic risk score. And then you can actually see to what extent genetic risk score is associated with the disease. That can inform whether the measured is actually the real association, whether it's due to some reverse confounding. And then for diabetes, as you can see, this is actually very similar in terms of direction, to magnitude, to what we have observed between adiposity and the diabetes. Confirm, the BMI is a cause of increase of the of diabetes. This is quite important. We also have done that for blood pressure. You can actually construct, we've got 50 blood pressure related to genetic variants, and put them together, you can establish genetic risk score. And actually the top quintile, bottom quintile, the difference is quite big. It's like, 6-7 millimeter mercury. And then you can actually associate it with that with a different disease. On the top, ischemic stroke, hemorrhagic stroke, all stroke, major coronary event, strongly positive. This is actually, nothing surprising. We know for a long time, blood pressure is causally associated with cardiovascular disease. But interestingly, for chronic kidney disease, although the number are not big, we only have about 800, but it's complete opposite. If that's true, we're still working on that. This actually confirms blood pressure may be secondary, So it's actually the disease itself driving increased blood pressure rather than blood pressure increase the risk of causing the chronic kidney disease. So that's important for treatment, risk prediction, and or development of novel therapies as well. For various other diseases, again, as a sort of positive control, nothing. So actually, potentially, this kind of information is going to be very, very informative, combining genetic with environment exposure, and increasingly, our ability to turn sample into omic data, it's going to be transformed enormously. I think just before I came, we have a very interesting meetings, and with the company USA, they can actually measure 1,500 metabolites using 100 microliters of blood. We also have a collaboration with other companies in the USA called Semological. They develop technology which can measure protein, 3,500 proteins. So if we can actually measure all this, including genetic with a different disease, it's going to create a huge amount of data that can actually be used to inform future biomedical research, drug development. I think we have monitored the technology quite closely, but I think our next major research priority is to genotype all 500,000 samples, because actually intimate genotyping is a very mature technology, very cost effective, only $50. You can measure about 1 million SNPs. This is FE new sort of platform. We have also developed a customized sort of array in collaboration with BGI and FE. And so with the $20 million, $25 million, you can actually measure all 500,000 samples. And in the future, you don't need to go back to the sample. You can do a very large nested case control study out of the data rather than samples. So it's going to make the study much more effective and cost effective, much more efficient. So I think we are right in the course to secure larger fundings, and hopefully within next 2 or 3 years, we can actually turn that into the way. But I think the challenge is enormous. The big data we have already discussed, the early session. And so as a result, Oxford, has, managed to secure large amount of funding to establish called Big Data Institute, try to, materialize these potential opportunities provided by this big data. Just to summarize, I think it's, epidemiology, in my views, is going to be at the forefront of future medical research. Not just for biological research, but also for healthcare research, as I managed to give you some example, especially if we're able to link to the electronic health record and a great increase in the range of disease that can be studied. For example, rheumatoid arthritis, cataract, gallbladder disease, chronic liver disease, chronic renal failure. There's not much big study available now. We are able to do that. This also can improve the study power, disease classification, and also information generated will help improve the patient stratification and develop personal medicine. And also, one example I give is the genetic variants. You can actually link to multiple disease with the shared pathways. This is not possible in case control study because you tend to have one sort of disease. And suddenly in cohort study, you can actually link to many hundreds, if not thousand conditions. And especially if the study done across different populations, you have Chinese, Europeans, Africans, and then you can actually do a lot of a comparison that can help understand sort of particularly genetic loci that's relevant for disease causation. So all this information generated will be relevant for disease prevention, risk prediction, and the development of novel therapies, and will benefit population, not only Chinese, but internationally. So the challenge is the data analysis handling. So I think we need to reach out not to other sort of computer scientists, mathematicians, try to crack this huge data as well. And also try to form kind of collaboration globally, try to make use of these huge resources. Thank you very much for your attention.
Thank you very much. Very impressive work. I'm John McLaughlin. I'm just going to sort of moderate the Q&A, and I'm Chief Science Officer at Public Health Ontario, and I've had the pleasure of visiting. We met at a time when Kadoorie was still just very new, and it is so remarkable after about 8 years to actually see now the tremendous progress and deliveries. This next session, we'll have an opportunity to ask some questions with Dr. Roos as well. It'll sort of open into a discussion of kind of the big data, the deeper dive, the case studies. So Dr. Roos, you can join us on the stage as well, please. But I think at the beginning, we'll open it to the floor for some questions.
So a question about the Kadoorie data. It was noticeable that there is no depression in China. Are they just more happy, or is there a bias, a reporting bias in your database regarding mental health issue, depression, ADHD? How is it treated in your database?
I think we are also doing research using the linked data. It depends areas. Depression is a major problem. For the baseline questionnaire, we also have we call CD4 to measure to some extent their sort of depression, anxiety, and as well. So we're doing some work on that as well. Yeah.
Yeah, I could just comment on that. We're trying to look at DSM-4, DSM-5, and individual ICD codes. And things, I mean, I'm usually a lumper in terms of these things, but the more I look at the data, it looks to me like I should be a splitter, that we're finding different pathways through which people get diagnosed with these different conditions. I know it's not definitive, but it's kind of changed my ideas about the subject.
I think I agree. Sometimes it's a social taboo. They don't want to admit there's a depression. Sometimes they call completely different things as well. So I think that's also a challenge. Yeah.
And again, if I'm allowed, so with reporting also, do you take into account herbal medicine, Chinese medicine, traditional medicine? Because it could have like a big impact on the way things are being done or cross activity with drugs as well.
I think in hospital, we able to capture a lot of the treatment as well, including herbal medicine. I mean, challenging with herbal medicine, it's a complete mess. There's 20 different kind of drugs, very fancy name. You don't really know what's really going on, what it actually can manage to do. The claims is it's very grandiose, can treat everything. So it's very widespread use. So that's why actually the project we try to set up is to understand the current clinical practice. What are the challenges, including unnecessary use of various treatment, the procedures as well. So that's going to be very interesting.
Dr. Dar.
Abdullah Dar from the Dalla Lana School. About the Kaduri Biobank, 500,000 people on the biobank is a huge undertaking. Lots of ethical, legal, social, cultural, regulatory issues. How did you deal with all of those?
I think it's what I present. It's a very nice story. If I, after drink, I tell you a lot of, challenges, issues. I think in retrospective, the biggest challenge is not operational, it's politics. It took us 1.5 years to get permission. I mean, until the just very last minute, the foundation want to cancel the project because we can't get permission. Because of the intervention of a, health minister, rescue the project. So actually, looking back, there are various stages, there's a lot of issues. Try to convince Chinese government, and this is a big project, it's going to benefit health in China. When we started, no one believed this is a credible research. People thought, Framingham 5 saw you want 5 million, 500,000, and there's no hypothesis, it's open-ended, and involve collection of blood, etc. DNA samples, they said actually, what if DNA samples get out China, American develop genetic weapon against Chinese? So all kind of the concerns, it's genuine, it's very real, it's very real. So it took us many, many years actually to engage policymakers, ethicists, and health bureau. So so we managed to do that. I think we follow another things actually. This is the way we introduce is follow international standard for the study. Very strict consent procedures written, go through all the approval process internationally, nationally, locally. So I think that's also important as well. In terms of recruitment rate, it's not very high. We managed to achieve 30%. It's not 100%. It's only 30% response rate, but it doesn't matter. This is a cohort study. We're studying disease association rather than actually the preference for the national. But that's fine. If you have a concerns, you don't turn up, that's perfect, all right. So I think, similar issues apply to UK Biobank. To start with, a lot of concerns, actually a lot of issues actually not found. If people have a concerns, they don't turn up, that's fine. I think you have to get evidence. I think UK Biobank has gone through a similar process, almost derailed because it's ethical concerns, and then they did some sort of, pilot study, demonstrate, it's all right, yeah.
Well, I think it's, as Dr. Roos had demonstrated, there's always lessons learned for the rest of us who would want to do some of these things. And so that might be a longer conversation. To bring some of the discussion back to the sort of original themes of the conference, a little bit more about the equity piece. And you've demonstrated how quite clearly the Kadoorie cohort allows so many different things to be done, whether it's genetics and clinical and biomedical. Could you comment a little bit about issues related to kind of the health disparities or evidence that could come from a large cohort like yours, and in particular then also whether or not the fact that you are delivering some product now, whether you're getting strong support from the local hosts and funders?
I think that's one of the main sort of consideration to start with. I mean, China is a huge country with huge heterogeneities in terms of disease patterns, stage of economic development. So there's a lot of study around Beijing, Shanghai, which in my view is atypical. It's not real China. So you have to actually reach out. So when we, in an early stage, when we selected, we say want to cover, wide geographic locations with the different stages of economic development, with the different disease patterns. That's quite important. And on its own, we got 50,000, which is a time-framing study. Over time, will become very informative for local health policies, for local disease control, for local sort of health education policies. I mean, same is true with the health insurance. Now we are actively engaging Health Insurance Bureau. It took a while actually to persuade them to open the data. And now they actually come to us, they said, there's a huge opportunity for this kind of research. We got a lot of money, we don't know how to spend them. Doctors actually keep prescribing expensive drugs, procedures. There's no way we understand what would be appropriate. So they actually want to work with us, not just 50,000, they want us to work with them on local 1 million, 2 million data. So actually that's very interesting sort of, changes in their mindset and attitude. I think it's all largely as a result of this collaboration. I mean, it's sometimes that's quite difficult, but once you actually get to know them, establish trust, and also make them aware, this kind of research is not taken away. We also provide a lot of useful research, help them as well.
Thank you.
Just one comment on that, and it's an area that we're kind of just getting into, and that is if we look at the Scandinavian countries, and well, I have a table I should have bought. We have the Scandinavian countries here and the United States here, and what we're looking at is not just things like school performance, which is important. In Scandinavian countries, the lower income quintiles do relatively well compared with the higher income quintiles, and not true in the United States. But it's also the sibling relationships, the within family relationships. And what happens in Scandinavia is you have a variation, considerable variation in school performance among children in one family. In the United States, you have a much tighter correlation at a lower level of school performance. And one of the interesting things for Canada on this particular measure is Canada looks like the United States, even though on a lot of other issues, they look more equitable than the United States. And some of the things with disease, with teenage pregnancy and so forth might respond to this analysis, not just across quintiles, but within families and how the family relationships differ.
Excellent. I'll come to this microphone.
Yeah, so I'll be brief in my questions. So picking up from a point that Prabhat made, the global population is aging, and aging comes with multimorbidity. On one of your slides with all the ICD-10, I'm a primary care, primarily geriatric population, they would have all of those things. The strategy I saw you presenting one was very much oriented towards isomorphism of gene to particular disease, but they may in fact have 3 or 4 of them. Some of them, for example, if they cluster around vascular disease, may share a genetic polymorphism, or so your multi-omics approach might work. But what in both Manitoba and China are you doing to address multimorbidity and medical complexity? And how are we going to translate that into a public health imperative to prevent multiplicity rather than single diseases?
I think this is a very good question. This is a research area we gradually start to get into. Previously, all mortality and major disease, as I mentioned, now suddenly open up as a research opportunity. I think, as I mentioned, every few years conduct periodic resurvey. So as a cohort is aging, so we can add various other new test enhancements like cognitive function. And also we also try to retrieve information from the hospitalized event, dementia, Alzheimer's disease, various other disease, and see whether we can actually use this as a platform to do kind of research. I think in terms of research strategy, actually it's very widespread. I mean, I highlight some other things, but at the moment, the best results are actually coming not from genetic, from conventional epidemiology. I share some results per pressure. I haven't really shared nice results, which we're going to submit to Lancet next week. Smoking. This is a big thing, smoking in China. It's already 1 million deaths now in China. It's still relatively early stage. So actually, this kind of research is very, very important to generate local evidence that can change the policy. And within China, there's still not resistance among government towards tobacco control. I think one of the ways to change that is actually local evidence. When they see evidence, they will act. I mean, otherwise they said, okay, American data, British data, where China is different. So that's always kind of this argument. And ARCO as well, we're doing a lot of research ARCO that could be completely transform our understanding of ARCO cardiovascular disease. Because it was genetic. So they are not actually separate. Sometimes they can actually inform understanding of environment, lifestyle factors.
Yeah, just one health services research kind of issue. There's considerable concern as a result of some work the center did. When you have a mixed system for nursing home patients, where we have they're scaled according to intensity of care that will be needed and so forth, of the non-profitable, the money-losing, whatever you want to call them, difficult patients being transferred, multi-morbidity patients being transferred to the hospital so they don't spend their last few difficult days in the nursing home. And this may be a public versus private sector issue with considerable financial issues there.
David Henry?
I'm going to organize this prerogative and ask 2 very quick questions that are technical to
I might let you have 2. We'll see how long the first one is.
I'll see if you'll let me get to the second one. The first one is, these multiple case control analyses that you're doing with your data sets, what adjustments do you do beyond maybe age and sex? So that's number 1. Number 2, it's about multiple testing. We're dealing not only here with large numbers of SNPs or combinations of SNPs. We're now looking, because you've got big data, at multiple outcomes. So you've got this matrix. So what about multiple testing?
I think in terms of stat adjustment, we try to take, age, gender, smoking, alcohol, education, locality. That's a standard. And depends on the research questions, we may consider physical activity and a diet as well. I agree, one of the biggest challenges is multiple comparisons. At the moment, we just use, for GWAS, we use, I think the key things actually is the analysis plan. For example, with that, you don't have to go for 10 to minus 8. It really depends on hypothesis. Actually, for some questions, we have a set of well-defined, pre-specified primary, secondary outcome, very much like TRI. I mean, the case I presented. If you have an 8, you can actually P less than divide by 8. So you don't have to go for the very extreme. But I think it's all down to the way data is analyzed. Before you do fishing exercise. So I think that's at least that's one of the strategy we have used. I mean, if we go for complete sort of a hypothesis-free, efficient exercise, yes, the challenge is multiple comparison. We need replication. We need to consider maybe system biology. Sometimes p-value is a less issue. Yeah.
If I can comment, I will come back to the microphone. There's a question that came on the board up there too that I'd like to make sure gets asked. But in terms of that point, it is one of the amazing things with big data now, how it is possible to go from associations to apparently causation by the very nature of the data and the ability to replicate and internally validate, and then also, sort through the biology of some of these types of things. Now, we will always be dealing with multiple testing or this very complex sort of scientific paradigm with big data. So that's where we need people who are smart thinkers and rock solid scientists. So that relates to the question that was posed up here. I'm not sure if this person was in the room or maybe couldn't ask the question because they're watching online, but from the U of T nursing program, now that I hear you talking here, how can I learn these research skills as a PhD student in nursing? And the point is partly that this forum is really meant to also give guidance to the formation of a university institute where teaching and training is really important. So I'd welcome to hear from both of you how can the young bright stars actually get into what you think is going to give them a good career?
Well, I have a daughter who is a graduate student whose first name is the same as mine, and said she had to take off 100 of my papers off her ResearchGate resume. So I do give advice for better or worse. One of them is, even though it may not be your thing, learn some programming. Higher level language is fine. I mean, MATLAB, SAS, SPSS. Take a couple of courses in it, even if you don't like it. It's good for you. One of the things is it keeps people, if you have a higher paying job and your supervisor programmer, you'll know whether they are kidding you or BSing you or not if you've had some coursework. That's very important. Secondly, take a course that involves writing. We had in my graduate program, there were a paper was due every week from one famous, but we thought sadistic professor, 4 or 5 pager on major things. And everybody said that was, 5 or 10 years later, that was the best thing they did in graduate school. And then the third thing is rather difficult. And Laura said she was doing with her students. Do some real data analysis where you get your hands dirty with the data, because sometimes you'll find people with master's degrees in statistics or epidemiology who don't have a feel for the data, and who can't say this looks wrong. And if you get that feeling for the data, you'll be right 95% of the time when you say it looks wrong.
Just to add on very briefly, I think the biggest challenge is to attract young, brightest sort of talent into the medical research. I think we're still facing very big challenges. I think the brightest, once they end up, they actually go to Google, they go to bank. I think they're all talking about big data, but in my view, actually, the truly big data is in health research. If you digitize one human being, that's probably, I don't know, God knows how many data you can capture. So I think this kind of research is going to generate a huge amount of new information. I think the key things is make people aware there's a great potential. Another thing is actually career trajectory or career for not sort of medical doctors, professors. It's for data scientists. I mean, they actually are critical.
They're going to rule the world.
They're going to rule the world. I think, at the moment, the university system actually do not recognize that. They're actually, sort of slaves working behind the scene, yeah. But they are critical in future. So we do need to create kind of a career structure for them so their contribution, talent, skills are recognized. I think, people start to recognize that, but I don't think, there's a solution at this stage. I mean, hopefully that can change the situation.
It's sort of, again, going back to the roots of some of the earlier conversation in this seminar, and similar to one of the first questions that came up about kind of governance and ethics and review. There's quite a few different career paths that people could take to be helping this type of work along, in addition to the data science side. Go ahead, can you? Yes.
Yeah, so my question relates to establishing data standards and how much time that you actually spend both within data sets and across data sets related to data standard related work. And I'll tell you why I'm interested in the question is, in Canada, there's been a lot of work done to try to advance the development of immunization registries. And there are thousands and thousands of doctors who are delivering vaccines whose data have to go into a population-based registry. And the purpose of this registry is for individual health as well as for population-based health. And I'm just wondering how much time with your big data you spend on that issue and whether you think it's an important issue.
Maybe I can just comment briefly on Kadoorie biobank, and then you can comment more generally. I think within Kadoorie, we pay great attention to the study design, standardization, because everything done electronically. I can talk about a day or two how we did it. We follow the strict standard. This is the electronic clinical trial FDA standard. So carefully designed, tested, and also with everything documented in SOP, IOP as well. So hopefully, all the variables be standardized. People can use not just internally, but also externally as well. So I think we follow that. But for external data source, it's beyond our control. So once we got the data, we spent a huge amount of time actually trying to process, standardize, code them, and then hopefully can turn into kind of a standard database. I don't think it's straightforward. You get the data, you make available. You need to invest huge amount of resources, expertise, in turning the data into usable standard format. I think that's that's what we're doing at the moment as well for hospital record.
Yeah. I think in Canada, the places like CIHI are trying to standardize the health information. There's real heterogeneity with regard to social and educational information that we don't have the answers to. Even things, what my personal position is to try to go with Canadian standards. We had a project where we tried to use the confidentiality, privacy questions, which Statistics Canada had worked at for years and years and gotten a consensus. And we had two people, this was where it could lead to a rant. We had two people who didn't believe in what Canada was doing, and in Manitoba with 1.1 million people said, we are going to develop our own standards, which are much better than the national standards. And by then I was at wit's end, and I said, thank you very much, but I'm not doing this research. And then in the back of my head, I said, we'll wait till you're rotated off the confidentiality committee and see if I still want to do it then. But I mean, there are some things you can't do.
Yeah, thank you. Dr. Choi?
I'm Bernard Choi. My question is very different from all the previous questions, and it relates to the very fundamental thinking and theoretical argument for the need for big data, wide and deep, and the need for that and how we get to that in the future. I just want to point out that when we start, that means public health research start. In 1532, it was the Town Council of London, England, that started the bills of mortality or the death records. And that was population-based. It was wide. It covered everyone. But it was shallow. It wasn't deep because John Grant was able to look at sex and location of death. Nothing else. No smoking data, no genotype. And then there was a need for deep data. And so we moved on to sample-based studies, cohort, case control. And then now we are coming back full circle to population-based big data, But as we saw from the presentations, population-based registries are still having these incompleteness and dirty data problem. And even for the deep, large-scale data, like 1 million people in China or in India, is still a very small sample. So it is likely affected by biases. In 1932, when there was a presidential election in the US, they had a telephone poll, opinion poll of 4 million people, the largest telephone poll at the time. But the predictions turned out to be grossly wrong because it used telephone, which was a luxury item at the time. It was highly biased. So how do we get there in the future, both wide and deep data?
That's a good comment. Would either of you like to comment on that?
Very briefly, I think we do need big data. I don't think there's any questions, uncertainties, if we're going to address big public health problems. I think with respect to the issues you raised, it really depends on the nature of research. If you want to understand the preference in the population, and the sampling is very important. But in cohort study, our main objective is to understand the disease association, the cause. You don't need to be nationally representative. So still, if you found smoking caused lung cancer among British doctors, and the results can be generalizable to general public. So I think that's a fundamental difference between different type of research and the need for different type of sampling scheme. Cohort study, the key things is understand disease association in which you don't need to be national representative. I mean, it would be good to have a great heterogeneity. You have smokes, non-smokes, different social economic development stages, but overall it doesn't matter if the proportion differs slightly. So I think that's a key thing we need to differentiate.
That's fine. Okay. Seeing a statistician at the microphone, I could maybe just interject briefly to say, but our statistics are always wrong. Sometimes they're useful. And so to your point, Bernard, I think if clearly the issues of bias and the why we're doing these types of work clearly have to be addressed up front. And in fact, some of the other sessions in the last 2 days have also raised issues like for who benefits, what is the value proposition? How does it help us deal with equity? How does it help improve health and get us away from a disease focus constantly? Those why questions, I think, are clearly consistent across the couple of days. Dr. Escobar, our statistician? Oh, yeah.
The statistician before the epidemiologist.
Okay. Well, now that I've been outed as the statistician, I guess my question was about what do you have for methodological core? I mean, this question keeps coming up. How do you get a feel for the data? And how do you develop these tools and build these tools? And as a statistician, the only way I can do that is by actually touching your data. And without that, and there are issues about how do you get access and privacy and whatnot, but I guess I see that as one of the inherent barriers is privacy is wonderful and great, but I don't want to know what Rob Ford's weight is. So I don't really want to look up his medical chart. So how do we get data scientists in it? One of the inherent barriers I see is access to data and actually being able to play with it.
I think both Manitoba and Ontario have issues with data access. In our case, you can get access to the data, but it's really kind of painful unless you have a local collaborator and you're willing to take time and bring money. In the Manitoba case, the amount of money we get from the university approaches zero. So we have to charge, and we charge everybody. I mean, and
when I was in the States,
yeah.
all big center grants have a methodological core.
Yes.
Which is they have a statistician or other types of people, professional data analyst types, or at the PhD level, to look at things and study those issues. And you spend a lot of money collecting lots and lots of data, and no one can do anything with it because all you're doing is just directing the SAS program.
Yeah.
So it does seem that you're identifying certain types of things that could actually be done locally or nationally to actually help with the access for smart people, whether established investigators or the up-and-coming trainees. One of the wonderful things about this type of work too is with Zhenming sitting quite often at Oxford but doing a major study in China, these things can be done from many different places now as well. So.
Just briefly on the data access, I think in China Kadoorie Biobank, we have an access policy available on the website. Hopefully next year we're going to open up, not sort of like UK Biobank complete open, but I think we're going to open bits by bits. You know, when the data is, we know, good stage, good shape, we want to encourage collaboration. So internationally as well. So if you have a particularly good idea you want to access, you can actually apply through the website. And in terms of a methodology, I think this is quite critical. Now we're actually working internally, not with Canada. I mean, hopefully in the future, we're working with, sort of mathematician Oxford, Rolls-Royce engine scientists actually trying to develop a methodology like 12-lead ECG. They actually, come up with a very nice novel ideas how to improve the algorithm. I mean, we got Minnesota code. They said, based on big data, we may be able to improve. So actually we give them the data, they actually play with that and may come up with something that could be clinically relevant.
Bioinformatics is a good example because that's where one can get data. And so people can say, I have an idea of how to tackle this type of data, and do it. If you want to get personal data on hospital admissions and everything else, I understand there are privacy issues,
but no, I don't think that's the issue. It's all going to be anonymized.
Yeah.
So,
I don't think that's a big concern. We would love to engage those who have the talent to actually work with these kinds of data resources, including the international, the national, and even the local. Dr. Zhao.
A comment on Dr. Choi's question on bias, which is related to Howard's question on inclusion. I think one of the important strategies, and certainly one we followed in India in the work, is try to be representative, even in the blood-based work. And in the Ontario population, if there were a blood-based investigation, I think that would also be a key strategy. So that's a comment. My question is actually to Zhenming, just quickly looking at the numbers, you've got about 3.5 million years of follow-up, if I did the math right, 500,000 times 7 years. Yet you've got 1.6 million hospitalizations. Does that reflect lack of primary care in China? And how much of that is people going repeatedly versus an average of once every 2 years I go to the hospital?
I think overall 50% of participants have had at least one hospital episode, ranging from very minor condition, which should have been dealt with by primary health care, like hypertension, diabetes, cold, headache, so everything. So I think that's why this is actually a very useful data source for healthcare delivery utilization research. We have actually just started a project on that, describing the patterns, and then actually that can feed back to the healthcare insurance company. But we do capture a lot of other major diseases I mentioned as well. So this is including everything, everything.
Thank you. I think we just have really time for one last question. I've just hit my limit, and Dr. Hu would be a good.
Thank you.
We can carry on the conversation later, but thank you, Dr. Hu.
This relates to environmental exposures, a topic that we've been talking about quite a bit in our own Big Data for Health initiative. If you look at the latest generations of large twin studies, like the Swedish National Twin Studies and others, what has become apparent is that we continue to severely underestimate the non-heritable, that is, environmental contribution to disease. We now know that about 90% of Parkinson's is probably environmental, but we don't have a clue what environmental thing. Now, you did mention that there are great opportunities associated with this study in China. And I applaud the marriage of the data with air pollution data that's there. That allows you to look at air pollution exposures. But I guess the question is, what else can you study? Because in fact, I've been to many, many meetings with our genetic colleagues, and unless you actually develop good biological markers or advance the exposomics concept, you'll never really be able to understand what the environmental contributions might be. And you haven't even begun to understand what the life course environmental exposures might be and address things like the fetal origins of adult disease hypothesis. So my question is, what are those plans like in the China study? What other environmental exposures? Are there plans to get at exposomics, but you can't really get at it unless you have a validated set of really good environmental exposures to begin with?
I think this is a very good comment. I think, I'll just give you a few examples of new study, which otherwise not possible. Air pollution is one. I think the advantage of that, we're able to link to the monitoring and also to study at individual level. Hopefully, we don't know whether it's possible. They're developing some models. And also to combine that with the other exposure, which is quite critical. If you look at Chinese newspaper, people say, oh, the air pollution, smoke, and the lung cancer is going up. It's driven primarily by air pollution. I don't think that's the case. Air pollution has been too recent to have any impact on the cancer. And it's the main driving force is the smoking. So actually you have to look at environment together with other changes. Otherwise you may get complete, sort of a biased conclusion. So I think that's the beauty of this kind of research. We measure, domestic air pollution. We are smoking, very detailed. And also potentially we can go back, specific to your question, to measure in-house, air pollution based on the household. I mean, we're also thinking, developing some sort of strategies, go back, periodically, different season to capture in combination with a sort of general atmosphere, air quality as well. So I think that's quite important. Another things I agree entirely. I mean, lots of things can be informed by new biomarker. It really depends on technology. So if there's a new measures, you can take to measure blood, which actually represents exposure to particularly by chemicals, and then you can actually measure them. And then you can actually establish whether they're any relevant for health or disease. And then you can subsequently do further follow-up studies and to what extent exposure correlates to blood, etc. Same is true for the nutrition. We didn't have a very detailed dietary questionnaires deliberately because we said it's impossible, Chinese diet. But we can actually measure something in the blood nutrient intake and then go back subsequently. So actually there's a different research, approaches we can take to address some of the forthcoming, the research agendas.
Right. Dr. Roos?
No, it's not an area that I have any expertise in. We did have a very interesting master's thesis that looked at use of pesticides in rural Manitoba over a period of time, and with some, interesting but not dramatic results, I guess, on health.
In a study like that, would that have been an ecological analysis over the
Yeah,
link?
they had quite small data to, like this farmer used this pesticide. The data were pretty good, yeah.
Okay. Well, I would like to call this session to a close, but please join me in thanking our remarkable speakers and their great accomplishments. Which takes us into, I believe, the next session with Dr. Hu leading this conversation. Thank you.
I am very gratified by not only everybody, and I believe there's been over 700 people who have cruised through this room over the last 3 days, but particularly the staying power of our scholars today. We're now going into a session that's focused. It's about trying to distill the insights that we've had over the last 3 days, but also get at the very implementable ideas that a university institute with its partners can do in global health, looking at each one of the sub-theme directions that have been articulated during these last 3 days. We do have a format, and we have a set of rapporteurs who have been charged with taking the visual graphics that have been generated by Lisa Edwards, the notes that an army of student note takers have produced to capture the ideas, and distill them into some take-home messages for us today to discuss. And we have a panel of respondents. And I'd like to welcome those respondents up to the podium. They include Erica DiRuggiero, the Associate Director of the Institute for Population and Public Health at CIHR. Erica, please. James Chauvin, the past president of the World Federation of Public Health Associations and Director of Global Health for the Canadian Public Health Association. And our own Abdullah Dar. Where's Abdullah? Where's Abdullah? Yes. Who's has many, many hats. Who's chairing advisory and scientific boards for Genome Canada, has been an officer for Grand Challenges Canada and a number of other organizations. And they'll provide some reflections on the rapporteur comments from the perspective of what some of these large government funded or NGO institutions may see as implementable ideas of the ones that were generated today. So let me first call on Alex. Are you the rapporteur for the first one? Yeah. And I think we'll see if we can put up on the screen some of the reflections that were captured. There we go.
Well, hello. How are you? Have you enjoyed the summit? Okay. Thank you for your presence here. And while we sort out some technical issues there, I remember, Howard, 18 months ago, when this was an idea. And I was really worried because we didn't know if it was going to receive a positive response. So I said, what would be successful? Say we get 50 people registered. We're absolutely thrilled when more than 700 people signed up. So we had over 700 people participate in the 3 days. So our Uber co-chair, Rani, who still should be running around, is the co-convener for this particular cluster, about which I'm going to report very briefly. But I want to remind you something I showed at the very beginning. For those of you who were at the session, the question was, is this half full or half empty? And I took you through an exercise that I hope convinced you that this glass is full. It's full of air and water. Yeah? And I think this is what we have seen during the event. We have a full glass. A glass full of opportunities, a glass full of talent, enthusiasm, wonderful ideas, but also a glass full of challenges, humongous challenges, that we could only address if we joined forces. And I remember one day when somebody asked at a meeting, what would you die for? And that was a question that was asked many years ago. What would you die for? And people would say, I would die for my country. I would die for my flag. I would die for whatever. Now, that question may not lead to a serious answer. So at that meeting, somebody said, why don't we ask, what would we live for? What would justify our existence? What would make it worthwhile? And I really cannot imagine a better answer than love. And you would laugh, huh? And I was expecting your laughter. As I'm sorry? No, it's not about prophecy. If you dig deep enough, you find love no matter what you do or where you are. And I think what we are doing here is an act of love, okay? Full of good intentions. And that can always backfire. So another message we received during these 3 days is that we are dealing with very complex issues and that we need to be very humble and very generous if we are going to resist the forces that will try to oppose an equitable world. Yeah? So now that the panelists are here and mic'd, English is a beautiful language. We can make verbs out of anything. Deplaning. Yeah, okay. Exactly. Okay. So I would like to share with you 5 points that came from our session, which is the foundational theme for the summit. This image, for those of you who were not the first day, represent what might be the only atlas in the world with data on health indicators, no indicators of the reduction in the prevalence of disease, which is what we tend to consider to be health. But I think we have all concluded by now that health is much more than the absence of disease. It is possible to have illnesses, multiple chronic diseases, and be healthy. So in keeping with the objectives of the summit, which is to try to come up with ideas that would help us shape the agenda for the Dalla Lana School of Public Health in general, but for the Institute for Global Health Equity and Innovation, I would like to share 5 with you. Our proposal for research is the first longitudinal, truly global study of self-reported health, including all nations and all ages. We don't have data from children, we don't have data from old people, okay? And we have a patchy picture from around the world about how healthy we humans are. And as it happens with pain, until we find a better alternative, the best way to judge a person's health is by respecting the person and asking the question, how healthy do you feel? And we are really encouraging from this group us to respect how we feel. Yeah? Because it's very easy to judge a person as not healthy if there are diseases diagnosed. So I think we have a unique opportunity to do this. We, the Saluto generators, of which there are 3 or 4 in the room from all over the world, also were shocked at realizing that there is no data set. And for this, we want support from our friends from the big data community. We have no global data set on the prevalence of disease. We don't know how many Canadians, what proportion of Canadians, for example, are free of disease, acute or chronic. Okay? And even when we looked with Alberto Ruiz, who is sitting here, and Natalia Pache, for data on the prevalence of one disease in one country, we found multiple data sets with different answers. So we could not even judge the health of the population on the basis of the absence of disease, because we really don't know what the proportion of people with disease is. Okay? So we hope to complement this study on health with data on disease. We need more indicators of health, salutometrics, to complement our pathometrics. And stimulated by what happened during these 3 days, we believe that we should not focus just on the individual or individual people, but that we are not separate from the planet. It's an illusion that is humans and the environment. We are part of the environment. The atmosphere is an external organ, as Alan Watts described it, and Buddhists keep reminding us. We could not exist without air. Okay? So we would like to encourage innovation in measurement, in assessment, because some of these things might not be measurable with numbers. But we need to be able to assess them, to judge them. In terms of education, and it was said several times throughout this encounter, we propose a safe space, not a safe space to talk, but a safe space to listen, and to listen to people with opposing views on all these complex issues that we have been discussing these days. And that safe space would enable us to generate ideas, but very bold ideas, very unusual ideas, that would give us a chance to tackle these factors, these elements, these issues that are making the world less fair. In terms of alliances, we would like to propose the creation of a global collaboratory for the creation and spread of health. Identify the best available examples in the world that have made either a huge difference or a huge mess. Because it's very important to identify what has not worked and to celebrate those brave attempts to change reality that didn't produce the expected outcome. And lastly, our belief in abundance led us to propose to transform our immediate living environment, the Greater Toronto area, where we have over 200 different ethnocultural communities still living in harmony. We are not killing each other, at least overtly, yet. And yet is a keyword, okay? Because there is a pandemic of the tendency to hurt each other. So we believe that we could create a mini world within the Greater Toronto area, with populations from every country in the world, every religion, every cultural group, that would allow us to engage in a much more inspiring conversation about the future in which we would all like to live. And to gather the courage with a big dose of generosity and humility that would be required to try to create that future. And Michelle, a graduate student who challenged us yesterday here outside, said to me, why did you use the word "for" at the beginning? Because at the beginning of the meeting, I said we could create the best model for the world. And she said, why didn't you use "with"? I said, because I didn't think we were ready for "with" at that point. But after what we have witnessed in these 3 days, despite our remaining differences, despite the fact that some of us may be dissatisfied with what happened or didn't happen here, we are in a much better position to believe that we can actually not, create a different future. Yeah? A different future for which it would be worthwhile living. Thank you very much.
May we have some reflections, beginning with Erica?
Okay, well, I think you've given us a lot of food for thought. I actually have something to say about all of these things, but maybe what I'll do is just pick a few. Let's start with, I think, the global longitudinal study intersected with your idea of innovation, which was very much focused on indicators. I think one of the things that I've observed, and certainly one thing that our institute has been trying to do is, while we do want to collect a lot of information at the individual level, I don't think we do a good enough job at collecting better measures of the environments. And as a result, our solutions end up being very technocratic and more biomedical in nature, and the solutions, therefore, are more individually focused. So how can we do both? We still need very good individual level data, but I think we also need to be doing more work at identifying and measuring the environment. So what do I mean by that? I think we need better measures of what constitutes our environment. So as we were challenged this morning, the social institutions that make decisions for us, that intervene on a daily basis, whether we realize it or not, the policies and programs, getting better measures of that. And research needs to be, I think, directed not just to measuring the problems. The prevalence of disease is absolutely important, but also the solutions, which means we also need better measures of the environments in which we live, play, and learn and grow. The second thing I wanted to suggest, which I think ties in the alliance and the transformative project idea, is that given Toronto's very multicultural nature and connection of the diaspora to other parts of the world, how can we learn about mobility issues and the connections between different countries? I don't think we do a very good job at also doing more comparative cross-jurisdictional research. And I don't just mean at the nation state level, but looking at ways in which we can do research that may support and better understand how different policies are implemented in different contexts. A lot of the research efforts have been very much focused on does it work, but for whom and under what contextual conditions, and what do we mean by the social, cultural, and environmental context in which we make those decisions. So I think as a funder, of course, people will want to say, do you have money to do all of those things? And as I was joking earlier, yes, I have my checkbook, but my purse is over there, so it's a little too far away. But all joking aside, I think one of the ways in which we're trying to do something about that is through an environments and health initiative, where we are actually going to be leading next year a major program of research that will encourage many of you to look at intersectoral action and putting the emphasis on research that will measure how different sectors actually can come together to develop the solutions. And the three areas of priority are in the area of agri-food, but to tie it to one of the themes of this summit, actually cities is another big area of focus. So those are just some of my reflections, and I'm sure I could say more, but I want to leave the opportunity to others. So
yeah, and I would really like to encourage CIHR to push the envelope. I have been a member of several review panels, and I think we as Canadians, and thank you for that, I hope we can support this kind of work. I think we have a huge responsibility. And so what we are proposing is to create a mini world where we could have the difficult conversations together and then invite the rest of the species to join it, really. And yeah, whoever wants to play along. And what better place than Canada? Okay? And we have a very narrow window of opportunity, okay? Because we are changing. Our brand is changing worldwide and very quickly. So we need to use that window to assume our responsibility. In this case, small is beautiful. The fact that we are almost invisible is very important. We have never been an empire. Okay? And that's also very important. And I think we need to shoot for gold or for rhodium, and if possible, and as a community. So it would be wonderful to work with CIHR on that.
Let's have some additional quick reflections from James and Abdullah, and then we'll move on.
Sure. Thank you very much. First of all, I have to admit I'm a very ardent Montreal Canadien fan, so for me to talk about Toronto might be difficult. So we'll leave that one for
welcome to join too.
No,
so am I, actually, Montreal Canadian. Yeah, so there you go.
No, but thank you very much. First of all, I want to thank you very much for organizing this incredible symposium. I've learned a lot and been exposed to a lot of really excellent critical thinking. And I've taken copious notes. I want to apologize to people who sat next to me or in front of me while I was typing on my computer furiously. But really, it was a very excellent educative process. I was particularly turned on by this morning's conversation around power, politics, and privilege. Being someone who's been involved in policy development and advocacy, public health is political. And I think there were so many lessons out of that this morning that are pertinent to what we're talking about here. And like Erica said, for me, the research, I would like to see much more applied research for advocacy purposes. What is it we want to achieve? And then how do we do the good advocacy? How do we do effective advocacy? And as you said, looking at the results of our advocacy, what influence have we had on different policies and practices, as well as who has benefited from our advocacy. And I think those are questions that we need to be looking at. I also would like to suggest to you, I am here representing the World Federation of Public Health Associations, which is the global body of the community of public health associations around the world. We have 105 organizations as members, of which 85 are national public health associations. And they are not well known, unfortunately. They tend to have a low profile in their own countries, but they're also not connected often into they're often overlooked by the academic communities. And I think this is unfortunate. And I think it's an incredible resource for you and for them to be linking and working together on these issues that we've been talking about. And I think they would be very happy to be involved with you on these research issues, and also building an alliance. I think the World Federation would certainly like to build an alliance with the Canadian public health community, in particular the Canadian schools and faculties of public health. I think this would be fantastic. And I also like to just say that one of the events that we do is the World Congress on Public Health. The next one will be, the 14th will be in Calcutta, India next February, and I'm delighted that Dean Hugh and his colleagues are coming over to talk exactly about what you've just done at that World Congress. We hope to have about 3,000 people from around the world there. And if you can use that Congress to ignite this pandemic of health on a global scale, I think it would be fantastic. I'd also like to indicate to you to think about the next World Congress, the 15th, which would be in Melbourne, Australia, in April 2017. Can we start planning for that, and how do you carry this forward into that venue? So I think there are some excellent opportunities here of working together with the public health community. So
thank you, James. Abdullah.
Thank you. As I matured, three things have happened to me. One is I've learned the joy of being thrown in at the deep end. So at lunchtime, Howard asked me to talk here. I knew nothing about it. Secondly, I've learned to reinterpret the mandate that I'm given. So I'm not going to talk about what you wanted me to talk about. And thirdly, I've discovered that I like being on the boards of organizations that give away money as opposed to being at the other end, the receiving end, asking for grants. So at the moment, or at least now and in the very recent past, I've been on the governing board or the board of directors of Grant Challenges Canada, which is just 4 floors up from here. Genome Canada, which funds large-scale genomics, stuff that is very relevant to big data. The Global Alliance for Chronic Diseases, which I was involved in creating and then led for 2.5 years. And as of last week, the World Diabetes Foundation. So what am I going to talk about? I'm going to talk about 9 bullet points to young scientists who are seeking money. I started off seeking money, and I was, I think, relatively successful. Now I'm on the boards of these organizations that give away money. So what have I learned? The following 9 points. Those who are tweeting, please note. 1, get onto the mailing lists of these organizations that you are targeting to fund you, and then get into their minds. Try to understand what is in their DNA. What is it that they're trying to achieve? What's the philosophy of giving away money? And try to predict where they're going next. Third, they all put out RFPs, request for proposals, or request for ideas or whatever. Get deeply into reading them. Don't think you can apply for a grant without understanding the RFA or the RFP. Read it very, very carefully. Call the officers, the program officers, particularly the young ones, will give you secrets. Ask them for hints and read the FAQs on the websites. You will learn a huge amount about how to approach the grant that you are going to write. Talk to people who have previously been funded by that organization and ask them, how did they succeed? What were the secrets? There are always little bits of things that differentiate the different organizations, and you need to understand that to be successful. 6, don't always try to be the PI. To be the PI on a $25,000 grant is not as good as being an associate PI or a partner in a big group that has a $10 million grant. You're going to achieve much, much more by being part of a really big and excellent team. So wait for your time to be a PI. But as a young scientist, don't worry too much. Your CV at that point doesn't require you to be a PI. Just join teams, think how you can work together. Number 6, you will fail. You will fail, you will fail. Don't give up. Keep trying. Always keep trying. Number 8, PIs who are writing grants, and good PIs are always writing grants. They always need help. So try and develop some skill, even as a graduate student, that's useful to people who are writing grants, and volunteer.
Just go to them and say, I heard you writing a big grant. Do you need someone to do a literature search for you? I'm there. I'll do it for you. Something like that. Develop a reputation for being a helpful guy to whom PIs can go to get this kind of help. And very soon you will find yourself on those grants, in addition to learning about how to write grants. And lastly, see who in your institution has just received grants. And grants always mean graduate students, good grants. So somebody has just received a big grant to do major diabetes epidemiological study. Study what you might do as a graduate student for that grant and approach the PI who's just got that grant and say, look, I know you're going to require graduate students. I've done my homework. This is what I think you should do with your grant. Employ me as a graduate student. There's 9 points for success in research funding. And everything we have heard this past 3 days going forward will require research funding. These are some of the secrets. Thank you.
That's Abdallah's wise advice to young researchers. I have a plea for the older ones. How could we devalue money? Money is at the heart of inequity. Yeah? If only we had different economic models, if only money wasn't the main indicator in many cases, if money were not the main driver for our decisions. Yeah? So I wonder if part of the outcome, in addition to getting great grants, would be to figure out alternatives for us to mobilize our sources of wealth. Yeah? Our talent, our enthusiasm, and to figure out alternative ways to getting what needs to be done. Even at lunch, we were talking about people need tenure. People have to get through the path. What is the role of those of us for whom those issues are not that important? How can we complement the two worldviews? So many of these younger people don't have to sell their heads to buy hats.
Well, you've heard many pearls of wisdom going far beyond our initial topic, but let's keep going because this is all an integrated process of learning where we want to go in global health, but also how we're going to get there. Let me call on Ross Upshur now to take us to the next theme. Thank you very much, Alex. Preventing the preventable.
Yeah, well, gee, you don't want to get me started on senior investigators. So it was interesting, this talk about grants and money and coming to Toronto. So one of the wicked questions I wanted to ask is, how do we monetize the successful career of a northern global health practitioner, tax them and invest that money in southern institutions so that they have adequate salaries and facilities. Many of us, so anyhow, let's just park that because it's not going to be very, well, we'll come back to that. So my slide. Elena, is the slide there? Oh, there we go. So yes. Howard's not going to be pleased with me because I just answered yes to all the questions, but I'll follow it up. So in a conference where the word justice has been used repeatedly in various ways, it would be an injustice to reduce the discussions to one slide. So we have had absolutely fabulous. So just to repeat and recap session 2, which is preventing the preventable, we started with an absolutely lucid account, a tour de force account of the functions and the components of a health system by Julio Frank. And this was absolutely gorgeously captured on our picture out there. We were to talk about, so the 3 key elements coming out of that I think we need to remember going back as we finish up. Julio talked about how we're in the midst of a massive transformation on various different levels, epidemiological and at global level. He talked about how complex health and health systems are becoming and how health is no longer just the purview of health experts. And finally, that there are multiple pressures on all of these processes which are driving us in different directions. So we'll start with, I'm using Alex's template of abundance, alliances, education, innovation, research, but I flipped it in order. Instead of landing on abundance, I thought I would start on abundance. And the reason I say yes is because what's become abundantly clear, both in our session and throughout the 3 days, is there is an amazing amount of talent, energy, wisdom, youth, and commitment, all wanting to be harnessed towards what IGGI wants to provide and to stand for. So we need to harness that abundance. And the interesting thing was the willingness of everybody that was in all the breakout sessions and that I've spoke to between the sessions to participate in that. So we have, as a go forward, abundant goodwill, plus we have the generosity of Paul Dalla Lana to support the school in its growth. Now we have to live up to that, those expectations, nurture and succeed. Alliances, yes. One thing that we found was there's multiple people around the world, and we had 4 systems represented. Our good friends from Ethiopia, from China, from Bangladesh and Brazil, who are all willing to be engaged, to actually learn from each other, to do what my colleague Anil Bhattacharya calls reverse innovation. And this leads to, I'll flip down to research, because there's opportunities that we discussed about comparative cross-system evaluative research. Some of that could be intervention, some of them could take on factorial designs, but there's a willingness to actually do innovative research on health system innovations, particularly focused at the intersection between primary care and public health, and a willingness to ask those questions. But of course, these are going to be complex projects with complex analytic. Oh, Franz and Lindy's still here, so the statisticians are still here. We're going to have complex analytic challenges that I think need to be addressed. Education, yes. People were absolutely passionate and interested about developing courses on a variety of clusters of events on prevention, on global health, on multiple elements. So we need to harness that willingness to create new courses. Some of those would be for our graduate students, but there is actually a tremendous appetite for continuing professional development. The number of people who are out in their career, or people like me, long in the tooth faculty members, who would love to refresh their understanding, to revive their skill set, maybe to transform their research into a slightly different zone, was massive. And I think we have the opportunities to do all of that through the auspices of IGGI. So one of the other interesting things that came out, and Stephanie Nixon led a breakout session on inclusion, is to remember that inclusion cross-cuts disability, disadvantage, Indigenous persons. We need to make visible the invisible and not lose sight of that. And James Orbinski, before he left, he said, "This has all been very great, Ross, but I want you to say one thing in conclusion, because I won't be able to be here to say it." He says, "What is this all about? Who is it for? Whose interests are being served? Where's the greater good that will come out of all of these deliberations?" So I think there is a world of opportunity. It would be actually now, I would say, an injustice for us not to continue these conversations. And the one thing that was clear in all of the breakout sessions was that they ended too soon. They wanted the conversation to go on. So despite our focus on abundance, alliance, education, innovation, and research, what does the university stand for? The university is the one safe place for ideas. It's the one place in our culture that actually values intellectual freedom and the capacity for humans to pose questions, have thoughts that may be dangerous and disruptive, but to support them and protect that freedom. So people want a safe place. I think that was in Alex's comments, where they can come and talk. They want to foster the conversation. And going back to my roots as started out studying classic philosophy, the polis, where we live, the freedom to speak, the ability to engage in critical dialogue with each other without reaching for hemlock or clubs, is what the university stands for. We must protect and nurture that and ask those difficult questions and harness ourselves collectively to that end. So I think I'll stop there.
All of you will be receiving an email shortly after the conference inviting you to join a continuing series of online discussion groups. And yes, this will be a never-ending summit. Any reflections from our 3 panelists?
You can go first, that's fine.
No, you go ahead. Ladies before John.
There is a Storify being done, and it's finished, and everything that has happened over 3 days is captured in the Storify. So I don't think we need to go through it again.
Yeah, fantastic. Good. All right. Thank you,
Ross.
Ross.
Just want to say something to Ross about, I used to work at IDRC in the 1980s, and I think IDRC was one of the greatest agencies we had.
Yes.
I think it's demised terribly over the past several years for whatever reasons. I think we need to advocate for the rebirth of the International Development Research Center, because that's what it did in the 80s. It provided exactly what you were talking about, the salaries, the infrastructural assistance to not only academic institutions, but non-governmental organizations that were doing research in developing countries and promoting their linkages to other organizations and institutions. I think we've lost that somehow. I think the other thing, what amazes me is on looking at the United States, and Howard, you would know more about this than me, is the amazing foundation culture in the United States that I don't see here in Canada. I mean, I think the Dalla Lana School is very, it's fantastic. You've got the support from Mr. Dalla Lana. I think it's phenomenal. But we need to be also building that foundation culture here in Canada of to support public health. And I don't know how we would do that, but I think it's something we do need to advocate for, because that will certainly help us open some doors around what we can do.
And now let me call in Katya Binho Campos.
Hello, everyone. I'm see if I can see my slides here. So I'm here to summarize lots of information that was collected during this cluster 3, and I just want to thank the students who did a great job and taking notes, and they take very good notes, and I'm going to share with the rest of the committee, because there is much more rich information that we can later on analyze for us to think of more specific issues on the urbanism and growth and in urban cities. But I just want to highlight, I didn't use actually Alex and Ross Upshur framework, but I think that framework of abundance, alliance, innovation, and education and research, it applied to all clusters, and I think we can fit in any of these clusters within that. I took more, let's say, a macro view of the contents of the information that we collected in terms of action areas, topics, issues that emerge in our discussions through the keynoters and the breakout sessions. So if you can pull the last slide. I did a summary of, oh, I have to do that. What is it here? Sorry. Here we are. So interestingly enough, I found that it's still, there's a need still for us to work on awareness, awareness of how our environment impacts us, how the greater opportunities that public health has in improving the cities, and also the role of the infrastructure to empower people to create better spaces, better urban spaces. The other thing that came up from the discussion was that the needs to create or understand the co-benefits, the need to shift towards a market mentality and to offer the higher marketing value for us to improve and to measure the performance. This was brought in the presentation by Jan when he talked about the wellness district. So very market related, and the need for market research for us to understand better the infrastructure, how we can improve and create co-benefits for everybody. There is also was very clear throughout the sessions, at least for me, that there is a need for coordination, for collaboration, the need to look of municipal and non-municipal policies for us to create better urban environments, and they need to bring multiple sectors, the cross-sectorial approach in our response to create resilient cities. The other point was, particularly when we discussed metrics, and we discussed metrics in our breakout sessions, was the need to develop standardized methodologies for us to be able to compare cities and to be able to track our growth and our progress. Developing metrics for, let's say, called soft indicators, like how are we going to measure good governance in cities? How are we going to measure collaboration in cities? How are we going to measure social capital that captures the process and mechanisms for us to work in urban environments? And there was also several points in different breakout sections about engaging communities and not only getting their point of view, the diversity of people participating in that development, and get a balance between citizens and real experts when you develop indicators. So we need to be more cautious about that. The other point was, let's make research accessible to all. From design the research, which means engaging the communities, to knowledge dissemination and knowledge use. We need to find ways and use technology for that, and need to find ways to make that a more in a more transparent way. The other point was, we need to understand how indicators are utilized, are used in decision-making process. Apparently, they still need to get more into that that field for us to, at the end of the day, to develop better policies. And last but not least, there is a breakout session discussing about technologies and how we can use technology to systematically capture particular social observations that may be in a quantitative way, we cannot capture that, but how can we use that to allow us to better examine the physical and the social issues in our cities? I think I live with that.
Reflections?
Well, I guess, as I said before, we've identified cities as really a top priority and one of our funding opportunities. I'll just say a couple of things. One of the things that we're hoping to stimulate through this kind of research, while there's a lot of research that's looking at very discrete exposures, we all are exposed in a cumulative way across the life course, and I think cities provide a really interesting environment where many different forces come to bear. And I think the data that was presented yesterday, I had an opportunity to be in that session, was phenomenal to be able to compare across cities, which again, I think provides a global laboratory for comparisons to learn about the experimentation that is going on. Quite expensive experimentation in some respects, but perhaps not enough research directed at trying to understand the processes that are leading to better health outcomes. And I think because many of the sectors that are at the center of making those decisions are not do not place health necessarily at the center of their efforts. What we're trying to do is, by engaging a number of different sectors, so transportation, public transit, you name it, in trying to elevate the place of health, but to also look at how we can better understand how these different sectors produce health. I think this speaks to another theme that did come up, I think, in the sessions, and that has to do with the concept of resilience. And so I was very struck by the fact that I think in public health, we've also operated very much in a deficit model where we look at trying to remove things from the environment, mitigate against threats. And while that's very important, what are the healthful features of the environment that need to be enhanced? And so I think cities do provide a really, and it's not the only example, opportunity for that. So in terms of funding, this is complex. This requires large programmatic teams. And so again, in addition to the work that we're hoping to support, I think the other opportunity is through our open competition. And let me just make a plea. I know people are not too happy about what's happening in the open reforms, but if you don't get your oar in the water, people will think that the public health community does not exist. And so we do need to apply, and we need to be applying, and we need to take Abdallah's advice about, don't apply until you're ready, and buddy up with more senior mentors and put together really solid, robust teams, because we need to put our best foot forward as a public health research community to say we're alive and well in this country, and we can do provocative, transformative research that makes a difference to the lives of Canadians and to global citizens. Unfortunately, there are many other researchers vying for those same dollars, but I think we do need to be going for it. So that's my plea. And then the final plea is the peer reviewers who are in this room, you are reviewing other people's research. And I am not suggesting you let bad, flawed research pass, but we have a history in our field of being very, very brutal. And I think other scientists have learned that it matters to really fund good science that makes a difference, but be careful about picking away at people's methods to the point that you've created a flaw that really is not a fatal flaw, but you've just killed that application. And so we have empirical evidence to show that this actually happens. And my plea to you is to be fair reviewers to each other, and please volunteer to be part of the College of Reviewers, because it will hopefully be your peers who are reviewing your research. That's the goal of this enterprise, and so that's my little plea to you. So there.
Thank you, Erica.
No.
Very good. Now let me, thank you, Katya. Let me call on Arun Chakalingam.
Wow. 3 days of solid science and information. Big data, big information, big knowledge gathering here. Can I get my slides, please? Talking about equity, I just cut down from 13 slides down to 4, and we'll live with 2. So it's a peer pressure, starting with 1, 1, 1, and I'm going to be taking just 2. Yeah, I'm just standing here in front of you, reporting on cluster number 4, achieving convergence. That's the work of so many other people. I'm so humbled and privileged to be here to present this. Next slide, please. Oops, how do I go back? Yeah, the main question that's asked here is, what kind of lifestyle or life should the future generation experience? And in your handbook, they've also given 5 different questions. But these questions were asked to the 2 key external vectors as well in their preparation. We have 2 brilliant people who have lifelong exposure, lifelong contribution for global health. We were fortunate to have both Dean Jamieson and Srinath Reddy here. And in between, we also had another star, Sulfi Buttar, our own faculty here, to intervene, to give a critical comment on the Lancet paper, which is a seminal paper for the years to come. I won't go through all of it, but based on that, we're trying to summarize the response to those 5 questions that were asked. The question number 1 is, how do we build upon the Lancet report on our way to creating and spreading health, the theme of this conference? From social determinants to social determination of health. I think that's a key point. Shifting everyday discussion to everyday action. That means using the levers that we already have, which we don't use. Perhaps it's time to use it. Then the second question is, how do these issues impact post-2015 SDG, that is Sustainable Development Goals agenda? The agenda should cross all sectors to develop equity within and between societies. And there need to be more on growth, development, resource, and just let me get the details clear. It should be independent of the resource model or growth dependent model. We should go away from that, or resource dependent growth model. See, there is only a finite resource in the world, and we are already consuming more and more and more. And how can you work with a zero-sum situation? Then the next question was on, how do we realistically take into account all factors affecting health, including those non-traditionally thought of as being determinants of health? So we need to create what's called create common societal goals around the determinants, and particularly around the notion that the society is providing equity. Fourth one is on, should we address convergence of indicators of disease or of health? Actually, both are important. Disease tells us where we are failing and where extra resources may be needed. Health tells us about how well we are furthering our primary goals. Certainly, we need to avoid catastrophic health system. The same old Western type of health system that we are promoting throughout the world in the name of global health. It is not sustainable in this part of the world. How is it going to be sustainable in the developing world? I think that's a question we should conscientiously ask. And the last question was, can we ever get beyond indicators of disease? Actually, it is imperative that we need indicators and metrics. We don't want to get away from indicators or metrics. We want to get beyond disease, but perhaps not orient our system solely to disease, but also to health. I would even emphasize primarily towards health. Include beyond biomedical all aspects of life. The United Nations Declaration says it should be intersectoral. It should be participatory by all societies. This is global health. The solution should also be global. And plan to mitigate threats. And we need to model on unintended consequences. So, this leads us to going forward, the one slide which everybody is talking about. So in terms of research, we did not put any particular question. We said improving implementation of what we know. Many of these things that we know, but we are not applying. See, better lifestyle, everybody knows, but how many of us are applying in our life? We speak volumes and volumes after it, but we don't apply. Innovating with attention to potential harm. The more research that we do, does it really help the people or is it going to affect the people? I think we should be conscientious. Modeling complexity for risk management and mitigation of threats. I think these are potential scholarly activities that can come out of universities like ours. Training. Listening for all the 3 days, I understand that the power has finally come. There are enough global work done in University of Toronto in silos. For the first time, we have all come together. We should make use of it. We need to go beyond traditional profession towards what Srinath called as the T-shaped competency at all levels. So we need to have some in-depth training, but we should have broader focus as well. Education catering to employability. Match the societal needs with education and training. We don't need to produce another degree program that does not give employment to the students or the young generation. We need to find out what the society really needs. It should be application-oriented. Finally, in terms of collaboration, it should be intersectoral, cross-discipline, cross-boundaries. I think we have now crossed the boundaries within the faculties of this great university. Now we should transcend across various schools in Greater Toronto, in the province, in the country, and universally. I think by collaboration, we gain more. By giving, we are gaining more. The giver gets, when you give something, there are two people to gain. The giver gets the pleasure. The person who receives also gains. So it is a matter of pleasure and global health. That's what it means. I'm quite happy to respond to the question.
I have just been reminded that we have a hard stop ending at 6 o'clock because, in fact, the Mars has another event coming in at 6 o'clock. So I'm going to ask Jennifer Gibson to go through her summary briefly.
We're going to use our fabulous graphic image for this purpose. Thank you. Okay. You're going to put it in the middle? Oh, great. Thank you. Okay. Doesn't matter? Okay. And we'll bring it up in just shortly. I just want to say a thank you to Lisa for these incredible graphics. And I wonder, I think that I can already see that these are going to be great teaching tools and great reflection tools for us within the faculty, just to be able to, again, revisit some of the questions and topics that we've been observing. Yeah, so our session was this morning, and so we're still in the pre-digestion phase of what we accomplished today. So what I thought I might do is just flag a few themes, and I think what's so interesting is that, in fact, although our session was on the third day in the morning, many of the topics that we were reflecting on today had precedence over the preceding few days. And so what emerged, and I think what struck all of us who were organizing the session and was also resonating with the panel, was how much there was a sort of almost a state of readiness for us to be on that day, that we had already started the conversation, and so we were tying a bit of a bow around it. Our key question was politics, privilege, and power, what really determines global health inequities? And of course, one of the starting places for us to be thinking about that was with Jennifer Prah-Ruger's presentation that started us thinking again about governance. And we know we just heard from Katia about urban governance, but there are so many layers of governance that apply in a global health context. And so being able to think really reflectively about this, and what Jennifer highlighted is that so often governance is understood as an interest-based type of engagement. And so she challenged us to think differently through some of her own work about how governance could be understood beyond interest to something that's more of a shared accountability and a shared set of concerns. She also flagged the issue of resources. That who has control over the resource is a source of power. Now that resource can be financial, it can also be, a resource can also be knowledge, but I think her key point here was that so often some of that resource control happens implicitly. It's operating behind the scenes in such a way that it's not always immediately visible. So shining light on this, it becomes an important point. And then she concluded by focusing in particular on the empowerment of women, highlighting that in many cases the empowerment of women has a direct impact on health equity more generally. Now, we had a terrific panel who took that as a starting point, but went much further in starting to unpack some of the other issues and concerns related to politics, privilege, and power. And in particular, where we started was, one of the things that tied all of the panelists together was that they were verbalizing in many ways some of the, as we started on day one, talking about some of the elephants in the room. And yet some of the forces that are incredibly powerful in shaping the experience of individuals. Janet Smiley named racism right from the get-go. And it was a range of different type of racism. She was talking about indigenous populations, but she also named another form of segregation or marginalization that has to do with epistemic racism. That is, the holders of knowledge, those who have the power to be able to disseminate types of knowledge, can also control some of the discourse and the conversation. And so she challenged, and was echoed by Walter Flores as well, to start thinking about different sources of knowledge, local knowledge, indigenous knowledge, knowledge of people who have lived or living in the experience, and to see that as a potential for a partnership to build thriving communities that are drawing from that much richer source of knowledge to be able to do that. We also heard from, Walter also was challenging too, the importance of political action as something that we ought not to be afraid of. And so one of his points was politics and power can be problematic, to be sure, but in order to respond to change, and to see material change resulting from that, we need to engage in politics and power activity as well. But it's the discourse that's different. It's different types of politics and power that would be operating in that context. Lisa Foreman, speaking from a human rights perspective, was the one who named and made me most uncomfortable when she flagged the invisibility of so many of the assumptions, the concepts, the values that we might bring to the table, or that we're operating under, but that we never look at critically and reflect on in an active way. And she challenged us to be able to shine light on those areas of invisibility, to name them, and to see how they are operating. And then finally, Solly closed off with some pushing us to think differently about how we envision. So he was encouraging us to do two things. One was to think about more of an ecological approach to thinking about health equity, moving beyond the individual, but also getting underneath again at the types of ways of thinking that might need to shift and to evolve in order for us to be able to grapple with some of these influences from the ground. And so one couple of strands that tied some of this through was, yes, we're trying to unravel complexity. And that's a theme I think that all of our sessions touched on. And some of that complexity has to do with power structures, political structures, social influences. And so that's a piece of the puzzle that we need to be shining a light on. It needs to be a focus of attention for scholarly work, but we also need to be able to see this not as a displacement of biomedicine and public health, but is potentially a critical enabler of achieving the ends of biomedicine and public health by grappling with some of these challenges and these issues. We also heard that it would be important to think about partnership, so partnership with communities, but in order to be able to expand the domain of shared knowledge and shared understanding that is going to undercut some of these influences, we need to be thinking about partnership in different sorts of ways. And so who ought to be brought to the table? Some of that partnership is across disciplines, so bringing disciplinary, divergent views to the table to start to enable some of that shifting, but it's also some of the populations who might otherwise not be at the table. And through that, to be able to work together to create public institutions that really push forward health equity in a way that is going to have a material impact on the ground. So what does this mean for us, though? I think we haven't had a chance to digest all the transcripts from the students that have been prepared at this point. But I think what it suggests to us is that from a research perspective, what we need to be thinking about is probably quite a range of different types of research that we need to be creating a space for. Conceptual, normative, and empirical, and to be able to bring those pieces together to address some of these issues and concerns. It also means that when thinking about the curriculum that we might be developing, or we might be engaged in as teachers, is to open up ourselves to be able to think about what are those normative positions, those assumptions that we're looking at uncritically, that we need to be able to shine a light on, to be able to work with our students to bring a much richer, much broader view. And then to grapple with, and I must confess, I'm not sure where I sit on this point, how to work with research and education to adopt a position of advocacy, to be able to, from this locus where we are in Toronto, to be able to really see some material differences by leveraging some of that co-created knowledge that we've got, focusing on these issues to be able to start to reconfigure some of the relationships that are affecting in very material ways how people are experiencing health equity or health inequity in the social context where they live. I'm just going to leave it there, but again, thank you to Lisa for a beautiful graphic.
Folks, we're in the home stretch, and let me call on John McLaughlin to finish with big data.
Hello. I haven't even had a chance to see a wonderful poster yet. So, but just really following on what Jennifer was just saying, there was a lot of connectedness, synchronicity, obviously, of the different dialogue over the past 3 days. And I would just really like to thank and congratulate Howard, the organizers, and to thank all of you for the opportunity to be part of this. In terms of the last session, I think I can be brief because many of you were in the room, and so this is the freshest one of all. The question that was asked was, how can big data accelerate global health progress? The first session had a range of speakers with amazing and very diverse experience who had been advancing knowledge, creating infrastructure, solving problems in completely different settings, in completely different ways, all very effectively and successfully. And a couple of bullets that I've sort of extracted from the copious notes that our talented note takers have taken. But so Prabhat, using a very inexpensive way, which was based on creating relationships and talking to people, a verbal autopsy. So I've said here, well, let's talk. And then he could also demonstrate that one can help the living by counting the dead. Very simple, but very effective. Zhenming Cheng's work showing through the Kadoorie Biobank that the huge accomplishment, there are both benefits, and he's demonstrated the feasibility of making a big and comprehensive project. And also he demonstrated that there were certain types of things for which clarity could only come from big studies. So it's not so much necessarily the depth of the data, and always it's sometimes the sample size, the large platform, which fit very nicely with Dennis Ross Degnan's approach to basically saying when addressing issues around disparities, that a population perspective is crucial. Know your denominator. So, you know, it's about being comprehensive. It is involving all and capturing that. So maintaining that population perspective. And then Rumi Chinara's kind of modernist approach to things, using social media, starting a little bit like what we just heard in the last session, the idea of being connected, going from connectivity to being connected through many different tools, which really did lead to some very novel and important insights that were corroborated by other more traditional measures. Following on introductions by Laura Rosella, but we had a deeper dive into the Manitoba experience with Leslie Roos. Lovely observation and affirmation that a little human touch and smiling persistence creates success. It created a sustained program with 30 years of success, and that human touch actually reflects, I think, back to the very first session, the love theme that Alex has actually introduced. It is about being aware, being respectful, really recognizing that we're here to, well, make things happen, and relationships are an important part of that. And then again, Dr. Chen's Kadoorie Biobank, but demonstrating more the depth of the linkage work, remarkably comprehensive linked data, and then he demonstrated such diverse applications. I've got 2 slides here. I'm really still digesting all of this, having just finished the conversation, but a few observations that relate to the themes around research, training, opportunities, and on the abundance theme, clearly there's abundant data. There's no question about that. There's abundant data, there's abundant need. There's also an abundant need for different data, and that's even where some of the social media types of the modern tools, the different tools, are actually very enriching. So yes, we can think big. Big data is possible. I would add, and I think it came up, recognizing that we're aiming to have big impact and big benefits, but some of the questions also sort of introduced the fact that just being bigger is not always better. We have to be clear about why and so what. Partnerships, again, consistent with other themes, collaborations. We're clearly in a new era of, while thinking big, we can only do big studies through collaboration. Global collaboration and real partnerships is now feasible and real for many different reasons, including the new possibilities created through tools, technology, mobile devices, communication. I would also add, I think that as part of the energy in the room that we've seen over the last 3 days, there's also a new possibility, a range of possibilities, because of the expectations that we have of ourselves, but I think society, even some politicians, and even some traditional biomedical scientists are beginning to realize, oh, well, we've actually been magnifying inequities. We've been making some things worse and not necessarily always improving, which therefore means that there's a recognized need to really begin to work harder on addressing such inequities that's coming from diverse sectors. And accordingly, there's a lot of momentum in this room from outside as well. So there's a real sense of let's seize that moment now, build this type of initiative, and then build on the momentum. Similar to other things we've heard, such as in training, the integration of different perspectives, such as in the cohort studies, the big platforms, they can look at so many different either associations or pathways and outcomes. And concerns about both the access to, in terms of controlling that so that it's respectful use, protecting privacy, etc. But also it's important for outcomes to be maximized to remove the barriers to appropriate access of such resources. My final slide then. So relationships are really key on this. Strong and real relationships and the fully and sustained partnerships and engagement are important. One of Alex's comments he made too, I'd actually picked up on too. It's convenient to use the word pandemic. Everybody knows about pandemics. But it's sort of, the word pan is across populations. It's not with populations. To be fully engaged, we really want to be working with our partners and having active and meaningful engagement. And that's for those places where there's great need. Janet Smiley captured it very nicely. You know, we need to be working with people more, groups and individuals more closely. Sure, Les Roos has indicated, well, yes, we must abide by the rules and we can save our rents for the partner. But in fact, for some of these things, we can write the new rule book because we are trying to engage and do things in such a way that it's not been, well, that rule book at least needs an evolution to actually achieve the high vision with the best motives possible. Leadership and talent, such as the leadership of the many who spoke here so impressively, the talent of the trainees that we want to also help, but also the people not in this room. There's tremendous talent across many sectors and disciplines. And so that does have an impact then on the training programs we receive. And we've heard stories and seen examples of how the global reach relevant to this institute, the possibilities through web-based learning, open source. There are so many ways to actually achieve that reach and to integrate across disciplines, which is clearly important. And then finally to I think one of the elephants in the room that we haven't really had a chance to explore yet is, have we actually started to deal with the determinants of our past failures? In particular, to fully engage with the same forces that have tended to favor treatment or drug discovery rather than distribution of preventive forces. Okay, how are we going to make money? Who's going to make money out of prevention? That's always been a problem. So taking that on and having that dialogue, one of the solutions I think is actually to create the value proposition that we can sell to ourselves, to the funders, to the community, because that's the thing that will create the career paths of our trainees. That will be the thing that gives something of value to communities everywhere. So it's the value proposition, and then making sure that we fix the problems that we've actually been making for quite some time, so that we can go from big data to big wisdom, as was proposed, and I would also hope big benefits and impact. Thank you.
Many of you know that I'm a recently arrived American, and I'm getting to learn that some of my favorite humorists are actually Canadian. Jim Carrey is one of them. But I would like to quote a very famous and treasured American humorist, Mark Twain, who said there's really three types of falsehoods. There's lies, there's damned lies, and then there's statistics. And that's just a plea for us not to take ourselves too seriously, to have fun as we embark in this adventure, our Institute for Global Health, Equity, and Innovation. And the journey's just begun. Like I said, you'll all be contacted about some of the discussion groups that we're going to form online. So this is not really an ending, it's really just a beginning. We're going to close now, but before I do, I first want to thank our co-chairs, lead co-chair Ronnie Kotha, Abdullah Dar, Alex Haddad, and where's Ross? Ross Upshur. They have done an incredible amount of work. And that you're still here on the last day at the very end is testament to that. And finally, our summit coordinator, Elena. Have you slept at all last night? Elena Andaniu, Jennifer McCallum and her team, thank you so much. This is incredible. I now officially draw to a close our Global Health Summit. Thank you for coming. Yeah.